Good evening, everyone. So today is a very important day as well as one of the sad day for the society. To start the meeting, I request our President, Dr. L. Venkatakrishnan, to give the presidential address.
Good evening to all of you, and today especially is a day which I think we remember in all solemns to pay homage to our one of the doyens of gastroenterology in Tamil Nadu, and who probably is, along with Dr. Professor KRP, really resurrected Tamil Nadu ISG and brought it up to this level. That is, we have to pay homage to Dr. Balasubramaniam, who is no more with us. So, without wasting too much of time, we'll start off with the case presentation, followed by the memorial meeting of Professor Balasubramaniam. Thank you.
I request the first presenter, Dr. Uday, to come over the dais. I request the chairperson, Dr. Murali, and this one to come over the dais.
Good evening, everyone. My case presentation is primary neuroendocrine tumor in the colidocal cyst. The F45. A 45-year-old lady. She is from Dharmapuri. She belongs to low socioeconomic status. She came to us with complaints of abdominal pain and vomiting since 2 weeks. And abdominal pain, which is acute in onset, biliary type of pain located in the right hypochondrial region, and which is radiating to the back. And initially, that pain was mild to moderate intensity for 10 days. And since last 4 days, it progressed rapidly to severe intensity. And because of severe pain, patient is not able to do her work, and she was not able to sleep also. And that pain is aggravated by eating food, and there are no relieving factor. Only after admission, giving IV analgesia, pain was subsided. And vomitings also since 14 days. Next slide. 14 days, there are spontaneous vomitings associated with nausea and non-projectile and non-bilious vomitings. The consistency is food particles, and there is no fresh or altered bed in the vomitus, and vomitings are aggravated by taking food, and abdominal pain which is there even after vomitings, it was not subsiding. Next slide. And the patient also complaining of itching, that is more during the nocturnal, and there is no issue of yellowish discoloration of eye or eye colored urine, and there is no issue of clay colored stool. There are no prodromal symptoms or fever and chills, and there is history of unintentional weight loss is there, and which was not quantified, and there is history of loss of appetite is there since 2 weeks. Because of pain, she was not able to eat food. Next. And there is no history of altered bowel habits, no history of decreased urine output. Next slide. Next slide. Past history, there are no medical comorbidities, and there is no similar complaints in the past, and patient has history of abdominal wall abscess, small abscess 1 to 2 centimeters in size, which was drained locally 30 years back, and history of tubectomy was done 20 years back. There is no history of blood transfusion, no history of drug intake or liver disease in previous. Family history, there are no similar complaints in the family, there are no liver disease in family. And personal history, she takes mixed diet, and there are no addictions, drug abuse or tattooing or any high risk of sexual behavior. And summary, a 45-year-old lady with no comorbidities and no significant past or family history came to us with acute onset biliary pain with vomitings, and there is also unintentional weight loss is there. Even though the weight loss is there because of her age 45 years, we want to rule out non-malignant lesions. So the pain duration is more than 6 hours. Initially we thought as acute cholecystitis, we want to rule out acute cholecystitis, and we also suspected cholelithiasis and biliary pancreatitis. Then we proceeded to general examination. On examination, general examination was normal and vitals are stable only. And on GIT examination, oral cavity, tooth caries are present. And on inspection, only the epigastric area, previous abdominal wall abscess drain, and previous tubectomy scar was there. 2 scars are there. And otherwise, rest is normal. On palpation, there are tenderness is present over the right hypochondrial region, and there is palpable hepatomegaly is there. In mid-clavicular line, hepatomegaly is 3 finger below the costal margin, and it is tender to unpalpation, surface is smooth, firm in consistency, and hepatomegaly that is moving with respiration. And below the xiphisternum also there is 3 into 3 centimeter mass is there, which is continuous with hepatomegaly, but the surface is irregular compared to rest of the hepatomegaly. The surface is irregular, and it is hard in consistency. The consistency is also different from the rest of hepatomegaly, and there is no splenomegaly. And on percussion, hepatomegaly is there, and auscultation also normal. And even though because of that significant hepatomegaly and within the hepatomegaly there is a mass, localized mass is there, so we suspected as a HCC, and also other DDs like intrahepatic cholangiocarcinoma and liver metastasis we suspected. Then we proceeded to the investigations. We did routine investigation. Routine on CBC showing only normocytic normochromic anemia. LFTs are mildly elevated, bilirubin is there 1.7, and HGPT and ALP is elevated 247 and 227. RFTs are normal, amylolipase was normal, and viral markers are negative. OGD we did, that is negative. Then we proceeded to do the ultrasound. On ultrasound we found a cystic lesion in the subhepatic region, and on the cyst, on the lateral wall of the cyst, there is a growth is there, and also multiple hyperechoic lesions in the liver with hypoechoic halo around the lesions are there. So provisional diagnosis they have given as a cholducal cyst with cholangiocarcinoma with liver metastasis. So then we proceeded to MRI abdomen with MRCP. On MRCP also it is similar only. It is showing a fusiform dilatation of the CHD and also the proximal CBD. On the right lateral wall of the proximal CBD there is irregular growth is there, which is infiltrating into the inferior surface of the liver, and also multiple metastasis is there. So they are giving a type 1 cholducal cyst with cholangiocarcinoma on the right lateral wall of the cyst with liver metastasis. And this is the MRCP image which is showing dilatation, this is the cholducal cyst, this is the proximal CHD and proximal CBD, and this is gallbladder, and there is and the rest of the bile duct. This is showing a type 1 cholducal cyst. This horizontal view, it is showing on the right lateral wall there is a growth is there, and which is infiltrating the inferior surface of the liver. And this is coronal view. It is also showing a cholducal cyst with growth on the right lateral wall of the cholducal cyst, and which is infiltrating to the liver. And liver metastasis also there. This is not clear in this slide. And because of bilobar involvement is there, we thought we proceed to for palliative chemotherapy. So prior to the chemotherapy, we want to confirm the diagnosis. Then we did a ERCP with breast cytology. And the breast cytology, and also we aspirated bile, we sent for cytology. Both came to be a negative. So during ERCP, we did cholangiogram. It is showing dilated CHD and CBD, this one. And because of breast cytology and bile cytology was negative for malignant cell, we want to confirm the diagnosis by image guided biopsy. Then we did a image guided biopsy. Surprisingly, the image guided biopsy histology, it came to be a neuroendocrine tumor. So then we proceeded with immunohistochemistry of the slide. It is showing 90% of the tumor cells shows moderate positivity with synaptophysin, and 30% of the cells have positive for chromogranin, and K index was 60%. This is histology slide. It is showing ovoid to round cells with increased nucleocytoplasmic ratios and diffuse chromatin, which is feature of a neuroendocrine tumor. And this is the synaptophysin stain, and this is chromogranin. Both are positive in the tumor cells. And because of it is neuroendocrine tumor, more than 1/3 of the tumors will have metastasis at the presentation only. So we want to rule out metastasis over the any other side. So we did a PET Dotanax scan. In this, it also confirmed that the CBD is the primary site with multiple liver metastasis was there. This is the PET CT. It is showing CBD. This is the growth with liver metastasis. And this slide also showing multiple liver metastasis. PET CT. And so after that, we confirmed it is a primary neuroendocrine tumor of the cholducal cyst with liver metastasis. Sir, and about discussion, there are only till now only 4 case reports are published about about the neuroendocrine tumor within the choledochal cyst, and all of them was diagnosed post-surgical only. After surgery only it was diagnosed. This is the first case which was diagnosed prior to the surgery, and first case to be started palliative creamer prior to the surgery. And most common malignant tumor in choledochal cyst is cholangiocarcinoma, that is adenocarcinoma. And these neuroendocrine tumor cells are arranged from, they came from embryo, they come from embryonal neural crystals, Argentafin and Pulcid scales. During the developmental stages, this neuroendocrine embryonal neural crystal will migrate to the GI tract and also the bronchopulmonary tree. Within the intestine, they will lie located at the base of the crypts of liver cone. And most common the incidence of neuroendocrine tumor in a bile duct is it is about 0.2 to 0.3%, but within the choledochal cyst the incidence is very poor. It is largely unknown because of very few case reports were reported. And why, how the neuroendocrine tumors will develop within the choledochal cyst is because of any chronic inflammation of the biliary tract by infection of biliary stasis, which leads to the biliary epithelium metaplasia will happen, and the metaplasia to it become an intestinal epithelium. After becoming within the intestinal epithelial cell, there will be increase in Pulcid scale. So because of metaplasia, there will be more number of Pulcid cell will appear, and there is high chance to they will become a neuroendocrine tumor. In our case also, patient has type 1 choledochal cyst, which causes chronic biliary stasis and chronic inflammation of the biliary epithelium. That might be predisposed the patient to develop a neuroendocrine tumor. And most common location for neuroendocrine tumor in biliary system is CBD. In our case also, it is CBD only. And clinical presentation, why it is very difficult to diagnose a neuroendocrine tumor prior to the surgery is the clinical presentation is similar to the cholangiocarcinoma. Most of the patient will present like a obstructive symptoms and abdominal pain only. That is similar to the cholangiocarcinoma. And these are usually seen in young women. Almost 1/3 of the patients with 1/3 of the patients of neuroendocrine tumors will have metastasis at presentation, and most common site is liver, second is lymph nodes. Our case also, the patient at the presentation also had liver metastasis. And this is grading, WHO grading. They proposed a grade 1 and grade 1, 2, 3 based on the mitosis and Ka index. Grade 1 and grade 2 will be described as a well differentiated tumor. Grade 3 described as a poor differentiated. In our case, Ka 67 index is 60%. So it comes to a grade 3 poorly differentiated tumor. And for diagnosing of the neuroendocrine tumors in biliary system, MRCP is superior than the CT. And MRA is also helpful to identify the any lymphatic vascular inflammation, and endoscopic ultrasound also helpful to get a biopsy. And these neuroendocrine tumor cells, they will expect they express somatostatin receptor. So PET CT with somatostatin scintigraphy is helpful to identify the lesions. But the drawback of PET CT is that sensitivity to detect the lesions less than 1 centimeter is only 50%, but its sensitivity to detect the metastasis is very high. It is 90%, and specificity is 80%. And what are the features that can helpful differentiating cholangiocarcinoma, neuroendocrine tumor from the cholangiocarcinoma are these neuroendocrine tumors are they present like a polyp-like lesions within the bile duct, and whereas cholangiocarcinoma generally they present as a mass obstructing the CBD. This is one feature. And also periductal infiltrating growth is seen in a cholangiocarcinoma, but intraductal growth pattern is seen in a neuroendocrine tumor. These two features help to differentiate priorly. And treatment, generally these are indolent course. So with surgical resection with negative margin will have life expectancy up to 7 to 9.5 years. 5-year survival rate is 60 to 100%. And maximum disease-free survival after curative resection is around 11 years is noted. And the main treatment of choice is radical resection is the treatment of the choice. And for a metastasis resection, it will be planned. If the radical resection is not possible, if we want to resect a metastasis, the only indication is life-threatening obstructive complications. And it is also recommended for only the well-differentiated tumor, not for poor differentiated tumor. But our case, patient having poorly differentiated with multiple liver, that is also not, there is resection is not possible. So next is chemotherapy. Chemotherapy is advised for grade 2 and grade 3 tumors. Cisplatin and etoposide is used for the chemotherapy. Our case also we started cisplatin and etoposide. The patient 2 cycles, we completed 2 cycles of chemotherapy. She is doing well now in follow-up. And how the prognosis of the neuroendocrine tumors is depend on the size of the tumor and metastasis and Ka index. Follow-up is for a well-differentiated tumors, like in well-differentiated tumor, grade 1 tumors, there is after complete radical resection with negative margins, no need for a follow-up. For grade 2 and grade 3 tumors, there is high chance of recurrence, so we should follow up by chromogranule levels and CT and MRI. For grade 2 tumors, we should do both every 1 yearly. For a grade 3 tumors, we have to do it every 6th month. And these are the 4 case reports published regarding neuroendocrine tumor within the choledochal cyst. These are the 4. Thank you very much.
Doctor, which image-guided biopsy you used for diagnosis?
Sir, ultrasound guided only, sir.
Ultrasound
Ultrasound
itself?
guided.
Okay, good. Anything? I just...
Good presentation, good work up to me. I don't have any substantial issues, but I want to point out certain inaccuracies in your presentation.
Okay.
Being a habitual examiner, that is our habit. We always like to point something or other because we don't want the candidate to go away that has done a very good job. First thing is when you said pain, you said initially moderately severe, then very severe.
Okay.
Nowadays it is better to use this pain score so that
Okay.
we will know whether the pain is increasing or decreasing or improving. That's one suggestion. Second thing is, still you are using this 1 finger, 2 finger, 3 finger liver size.
Okay.
It is better to measure the liver size and then, unless there is some difficulty in measuring the upper and lower borders,
Okay.
it is better to mention in the centimeters of the liver. Another thing you said, patient has anorexia. In the next sentence you said she was scared of eating. So is it cytophobia or is it anorexia? That you'll have to clarify.
Okay, sir.
Because it's slight difference
Very
in that.
different. Yes, sir.
And in your examination, did you mention about Murphy's sign? Because your first diagnosis was cholecystitis.
Yes, sir. No, sir. Not mentioned.
You didn't.
Yes, sir.
And when you presented the CT report, you said horizontal view. Is the term used for CT? Either it is sagittal, coronal, or cross-section.
Cross-section,
Isn't it?
oh.
Is it horizontal view is used? So these
Correct.
small
Okay,
inaccuracies, if you had done that, it would have been an excellent, even
Okay,
better.
sir.
Thank you, sir.
Thank you, sir.
Did you mention about the bruit over the mass which you felt?
Yes, sir. I mentioned, but it is negative only, sir.
Negative. Okay.
It may be, but not mentioned.
2 points. It's neuroendocrine tumors usually well vascularized tumors. So one should be very careful taking the biopsy.
Yes.
It can bleed actually. So you can go through a normal liver and take the biopsy actually, not going directly over the surface. Second thing is in neuroendocrine tumor, palliative resection is allowed in case of functioning tumors actually,
Function. Yes, sir.
rather than with the obstructive symptoms. Otherwise, it's a very nice presentation.
Thank you, sir.
Is a patient with multiple metastases.
Ah,
Suppose she had gone for cholangitis, 100% mortality. Could have straight away taken for guided biopsy, no?
Yes, sir. But better to do ERCP.
Why? What is the need?
Okay, sir. Sir, but
No, you just breast cytology, one biopsy.
Even breast cytology,
Breast cytology 50%.
advanced malignancy.
Okay, sir. But sir, first we didn't thought image biopsy, sir, because it is inferior surface of the liver. It is difficult to get biopsy from the primary site. So we can able to take the liver metastasis only, sir. The growth is there in choledochal cyst, sir, and that is inferior surface of the liver. And so it is easy to get breast ERCP and breast cytology compared to directly. So it came to be negative. Then through the liver we punched and we have taken biopsy, sir.
Lucky.
So that is
So-
correct.
Your biopsy report is from the secondaries or from the primary?
Primary, sir, not from secondaries.
No, this, your breast cytology, I think we have more or less started giving up now because even in florid cholangiocarcinoma, it's only about 30%. The other thing we use these days is spyglass. You can put a spyglass and take biopsies. You can look at the whole thing and then do it. So what's your plan on this metastasis for the liver on this? Now that you've taken on the primary tumor, why I say this is in neuroendocrine meds to the liver, if you're giving etoposide and cisplatin, and if you combine it with rituximab, and if you can predict a 2-year survival beyond that, if they survive beyond 2 years, I think liver transplant is a good option for a metastatic neuroendocrine tumor. They do liver transplant if you have shown a survival of 2 years after a course of etoposide, cisplatin, and rituximab. This is a group which came from Paul Brousse in France. And now Norway has got the highest number of patients who have undergone a liver transplant in a neuroendocrine metastasis. So one malignancy or one tumor where you could probably, next to HCC, where you could probably do a metastatic neuroendocrine, provided you don't have a nodal mets anytime after a chemo.
Any more questions? Okay, next. Thank you.
Sir. Thank you, sir.
So next present is by an interesting case of obscure overt GI bleed by Dr. G. Nayan Sri from Triplam, Chennai.
Good evening, everybody. Pardon my voice today. So I'll be presenting a case of obscure overt GI bleed. This was a 34-year-old male, Mr. A, who's a software engineer, presenting to us from Tirupati. He was referred by a doctor in Tirupati, who presented to us with complaints of melena for 4 days, 2 to 3 episodes each day, and extreme fatigue, nausea, and vomiting. He had like very little vomitus. There was no history of loss of weight or appetite. And there's no history of abdominal pain, fever, or bleeding from any other site or NSAID intake. He is also had similar complaints in the past. That was 1 year ago, for which he was treated with blood transfusion. Endoscopy and colonoscopy done that time was non-contributory. And his disease was quiescent for 1 year, totally asymptomatic for a year. Personally, he's got no addictions. He's a non-vegetarian and his sleep is good. And the family, he's got no history of malignancy in his family. On examination, he appeared pale and he has multiple subcutaneous nodules throughout the body and a few hyperpigmented macules throughout his body. Vitals stable and systemic examination were within normal limit. Digital rectal examination showed melanic stools. So what are our differentials at this point in time with the history and examination? Anybody would like to take up? A young male, no comorbids, not on any medications, presenting with obscure GI bleed. So usually with GI bleed, you can compare by age. If it's less than 40 years, mostly predominantly you will see inflammatory bowel disease, Dual-Foy's lesion, neoplasia is common in this age group, Meckel's diverticulum and polyposis syndromes. Above 40, it's angiectasia, Dual-Foy's lesions, neoplasias, NSAID use, and there are other rare causes mentioned. This one index called the OMIA index takes into account the comorbidities of the patient, and depending on the comorbidities, the probability of these diseases can change. And there is some difference between the Indian and the Western counterparts, the cohorts. The incidence of obscure overt bleed in Indians is more younger age group in the 4th to 5th decade compared to 6th or 7th in the Western. And due to that, the comorbids are less, and more frequent cause of infections being the cause of the bleed is commoner in Indian setup. So lab investigations, the hemoglobin was low with HB of 8 gram%, MCV is 76. The other parameters in CBC are fine. The SR is elevated at 102 per hour at 1 hour. The coagulation profile and LFT were normal. The transference saturation was 4% and B12 was low at 167. He had already come to us with the UGI and the colonoscopy repeated, which showed the UGI scopy was normal and the colonoscopy showed melanic stools. So how do you proceed after this? With an overt obscure GI bleed, after you've done the colonoscopy and endoscopy, what is the next step? So there's the algorithm, this is given in Schlesinger. For an obscure, and these are the guidelines, this is the ACG 2015 guidelines. After a suspected, so they no more call obscure overt GI bleed as obscure bleed because usually the location is small bowel. So they term it as small bowel bleeding. So if you're suspecting a small bowel bleeding and it is overt, you can do a repeat endoscopy if warranted, because most of this they have found are within the reach of a normal UGI scope and has been missed on the first investigation. If the repeat endoscopy is negative, then you proceed with a small bowel evaluation with an capsule endoscopy or a device-assisted endoscopy. And if you suspect an obstruction in this patient, then you initially do a CT, an imaging, and then move over, rule out strictures, and then do a video endoscopy. And after that, once you find the lesion, you treat accordingly, either by device-assisted endoscopy or by surgery. This similar concept in the European guidelines, but the Japanese, they suggest to do an, if your UGI and the colonoscopy is negative, they strongly suggest to do a CT scan or an imaging of similar modality before you proceed for a video endoscopy, unless and otherwise it's not available. Okay. So this was the enteroscopy image that, so because the patient was coming from elsewhere and he did not want, a 2-time procedure or something, we gave him the option of a video or a enteroscopy, but he opted for an enteroscopy. So this is the enteroscopy image that we found. Could you tell what enteroscope is used here? It is a power spiral enteroscope that was used, which you can tell by the motor markings. I don't know how the pointer looks. Yeah, this motor tells you that it was a power spiral enteroscopy, and this was the lesion that we found in the mid-jejunum region. So you can see it was almost a circumferential lesion with some necrosis causing partial luminal narrowing. So now, would you like to comment on any DDs for this case? Yeah, so adenocarcinoma and lymphoma and all that. So we took a biopsies of these, of this lesion, and in the meantime, we also got an imaging. Okay, before that, balloon versus spiral enteroscopy. There have been a few studies done to compare the efficacy of both, and what they have found is the yield and the therapeutic efficacy of both is relatively same, except that the learning curve is a little less steep for the spiral enteroscopy. So we did the imaging, and this is what we found: a heterogeneously enhancing mass around 8 by 10 centimeter in the jejunum, and it was being fed by the SMA. So what is the role of imaging in GI bleed? Okay, this is from the American College of Radiology, and they have given us the appropriateness of using imaging in GI bleed. The non-varicose arterial bleeding, then you use a catheter angiography if the patient is hemodynamically unstable. Non-varicose and you're not able to identify the source, then you can also use the catheter angiography. Obscure GI bleed, again catheter angiography has got the highest yield. And if endoscopy is contraindicated in these patients, then you can do a imaging study. In lower GI bleed, again with active bleed and hemodynamically unstable, you can do CT angiography. In patients with active bleed and unstable, again CT angiography can be done. In the rebleed or post-colonoscopic bleed, you can do a CT angiograph, which is most important. And intermittent or obscure bleed, you can do a multiphase CTE, which is comparable to a capsule endoscopy. So then the biopsy reports came, and this is what it looked like. So this is a spindle cell. You can see whole sheets of spindle cells with some ulcerations. So this is a gastrointestinal tumor. The other types being epithelioid and mixed. And then we proceeded with IHC to confirm the diagnosis, and it was positive for CD117 and DOG. DOG stands for discovered on GIST. This was the whole panel. So you can see the SMA, S100, the others were negative, and only the GIST markers were positive. So there are certain syndromes associated with GIST. The Carney's triad consists of multifocal gastric GIST, paragangliomas, and pulmonary chondromas. The dyad of that is called the Carney's-Traskis, in which you do not have pulmonary chondromas. And the other thing is neurofibromatosis type 1, in which small bowel GIST are more common. So this patient did have a few cafe au lait spots, but it was not very typical of a neurofibromatosis. Then we proceeded with the surgical excision of the mass. So you can see it is mostly an exophytic mass which has created a false lumen within, which is what we saw in the enteroscopy. So how do you follow up, like how do you proceed after this? Is surgery alone sufficient, or do you have to do any further chemotherapy or immunotherapy? I'm sorry, this is, I think the wrong slides came on here. So anyway, I'll just tell you about this. So what you do after, you are supposed to send mutational analysis for these GISTs so that you identify the mutation, and if required, you have to give treatment. And how do you decide if the patient needs treatment after analysis of, after operation? That is by the prognostication indexes, which we use the modified NIH or AFIP index. The modified NIH index includes size, site, mitosis rate, tumor rupture, and the size of the tumor. If a tumor has ruptured and if it is extra gastric, then the risk of recurrence is quite high. So if you're operated and it is a low grade or intermediate risk tumor, then you just have to follow them up. If it's a high risk tumor, then you go ahead with adjuvant chemotherapy, immunotherapy with imatinib. If it is inoperable, that is your margins are not going to be free if you operate, then you give pre-operatively, you give imatinib, and then once the surgery becomes feasible, you go ahead with the surgery and then again follow them up as for this side. If surgery is not feasible or if it's a high grade tumor, then you treat as for advanced therapy. So in advanced therapy, the mutational analysis helps how is because depending on the mutation, your treatment will vary. If you have a KIT exon 9 mutation, then you have to give a higher dose of imatinib. And if that does not respond, then you go to second line, which is the sunitinib. Then there's third line, regorafenib, and then the fourth line, that is ripretinib. If you have a PDGFRA mutation, then you go for evrapritinib. If there's an NRTK inhibitor, then you go for NTRK inhibitor therapy. All right? And how do you follow up these cases after the surgery and the immunotherapy? Is you follow up. The recurrence rate is highest after 3 years of stopping the adjuvant therapy. So till 3 years of giving the adjuvant therapy, you do a follow-up with either a CT or an MRI for every 6 months, and then annually after that, and 5 years, till 3 years after the adjuvant immunotherapy. And for people with low-grade tumors or very low chance of recurrences, the role of follow-up or imaging for follow-up is not well defined. Although the risk is not zero, so the follow-up is upon your discretion. You can follow up either every 6 months or annually with a CT or MRI. Thank you.
Good presentation, good show. But one thing I want to ask you, when
Yes, sir.
all these investigations were not there, how are you planning?
Sorry, sir.
When all this CT and all those things are not there, then how will you plan? You said so much hi-fi. How will you plan? Because 44 years back, I had a patient who had a bleed. 17 bottles of blood transfusion was done. Upper GI endoscopy negative, colonoscopy negative. What do you do? What will you do?
Did you have, what options did you have back then, sir? I'm not sure. I am not sure what they had.
I remember two cases distinctively. One case is my classmate. In fact, fifth standard he was my classmate. So I met him after about 18 years. So today I saw him in the ward. His hemoglobin was 14 grams. Next day I go, his hemoglobin is 4 grams. So many surgeons here, I will tell what happened. I rushed to Rangabhashan. He said, Raghuram, it may be negative laparotomy. Your friend must be prepared. I said, okay, sir. He did it. What happened was half of the intestine was filled with blood, half was normal. So in that half, he made a niche and did the sigmoidoscopy, rigid sigmoidoscopy, and found a vascular bleed. Right? That's one. Another patient who had a bleed, so endoscopy is normal. Again, laparotomy, enteroscope through the endoscope. He had a tuberculosis ulcer with jejunum.
Okay.
So you are living in luxury, madam. I started my career without any luxury like that. Even endoscopy was not available. It's a good presentation, but one thing I want to ask you, elaborate so much of GIST. What is your experience in gastro?
With GIST, sir?
What's your experience?
I just started, sir, this year.
The case of GIST you are seeing?
Mostly it was the gastric GIST that we have seen, picked up endoscopically, around, say, 10.
That's a fantastic number.
Before the general dictum, before you do a video capsule endoscopy or a enteroscopy balloon, I think we should always have a CT with a CT enterography. Because if you have a lot of, say, adhesions or something, you need to really plan your enteroscopy. Supposing you see a lot of adhesions, if it doesn't go, you need to be very careful. So this patient, I think, if your upper GI colon was negative, a CT angio would have picked up this mass.
Yeah.
And you could have just gone for straight away for a laparotomy. Even before you do your video capsule endoscopy or an enteroscope, it is generally said that you plan a CT enterography to make sure this thing. The other options is a CT enterography could have picked up a neurofibromatosis polyp in the bowel. You have come across a GIST. But some elderly man comes with this sort of, with all these nodules and a bleed, it's possibly that they are intussuscepting. So intussusception, the lead point in adult is always a polyp or a tumor. So it's mandatory that you do a CT enterography. And when you did a CT later, you found that it's all exophytic. So probably a CT could have been done earlier to a VCE or a enteroscopy.
Treatment?
Sorry, sir. So the mutational analysis is awaited, sir, which is the...
Yeah, if you are starting, how long do you propose to give?
3 years, sir.
Actually,
1
I had a
year.
patient, we gave for 5 years. After 5 years, we stopped, again recurred. So I think it may be a lifelong.
So what they...
I had a patient long ago. I think patient had imatinib for almost 10 years. After that, he had the problem. With 10 years, he was okay. He did well.
With 10 years, yes, sir.
Why do you want a mutation analysis in this patient?
So because if the mutations, like suppose it's an exokine 9, then we have to start with a higher dose of imatinib. If it's a PDGFRA, then we have to give abirapritinib. So depending on that,
But
the
your
specific immunotherapy.
immunohistochemistry is strongly positive for GIST.
Yes, sir.
Yes. So I don't think there's any harm in us starting him on imatinib.
And there's no harm.
Yes,
in the
yes, okay. Because this mutational analysis are going to be very expensive. And if patient does not respond to imatinib, then you can probably go ahead and do the mutational analysis. This is my take.
After prolonged use, they become resistant imatinib. We had one case after 15 years, patient came with a more aggressive tumor after 15 years.
For 15
So,
years.
yeah, please continue to take imatinib. Initially, we did the GIST, then twice liver resection. After imatinib came, we gave imatinib. 2, 3 surgeries done earlier. From the first surgery, after 15 years, he got married, 2 children also came with the recurrence. More aggressive form.
Thank you.
So thank you, chairpersons. To proceed further, I request the next set of chairpersons to carry out the next 2 cases. I request Dr. Basumani and Dr. Ravi and Dr. Kannan. Dr. Bharat, please come over the dais. The poem will be the last case. Next case will be IBD-related treatment issues, focusing on infections.
Good evening. I'm Dr. Anbu Kritika. I'm from SRMC. I'm presenting under the guidance of Professor Ganesh. So I'll be talking about 2 main cases. One, a 44-year-old male came with complaints of severe pain in the perianal region during defecation for 3 days with bleeding PR for 3 days. Patient is a known case of IBD, ulcerative colitis, on treatment for 3 years. He usually has a stool frequency of 3 to 4 episodes per day with mucoid stools, but patient had failed to follow up and discontinue treatment for past 1 year. Now, for 3 days, he came with complaints of increased frequency of stools with a frequency of about 15 to 20 episodes per day, mainly mucoid watery stools with severe tenesmus, with complaints of bleeding PR and the blood in stools is about 5 to 10 ml per episode. His main complaint was severe debilitating perianal pain while passing stools, burning type of pain so severe that he was even scared to defecate. There was no complaints of abdominal pain or distension or fever or vomiting or emetemesis. No other complaints of joint pains or skin rashes or oral ulcers or redness of eyes or cough or breathlessness. As I said, he is a known case of IBD UC on treatment since March 2019, but he had discontinued treatment for the past 1 year. There were no other comorbidities, nil addictions, no similar family history. On examination, pallor was present, his vitals were stable. Systemic examination did not reveal any significant findings. Investigation showed that hemoglobin was low, 6.3, elevated ESR and CRP. RFT electrolytes was normal and LFT was normal except for an albumin of 2.7. In view of his anemia, 1 unit PC was transfused, after which his hemoglobin improved to 8.6. Endoscopy was done, which showed a normal mucosa in the esophagus and the stomach. The duodenum, mainly the D2, showed a granular mucosa from which biopsy was taken. So the impression was severe duodenitis with granular mucosa. In the biopsy, we found that there was mainly cryptitis and increased eosinophils in the lamina propria in the second part of the duodenum. Colonoscopy was also done. That showed this kind of ulcer, well demarcated ulcer in the distal rectum with surrounding loss of vascular pattern and spontaneous bleeding spots. Sigmoid and descending colon also was severely inflamed with complete loss of vascularity and friable mucosa with spontaneous bleeding. Splenic flexure and transverse colon and hepatic flexure also showed inflamed mucosa with friability. The ascending colon, cecum and terminal ileum were normal. So an impression of subtotal colitis from the rectum up to the hepatic flexure was given with a Mayo of class 3. The biopsy showed mainly a distortion of the glands in the low power view, and in the high power view there was cryptitis and cryptabscesses. The report showed that the ulcer, this is the one taken from the ulcer, showed acute inflammatory granulation tissue. The rest of the colon showed architectural distortion with dense inflammatory infiltrate involving from the proximal rectum up to the ascending colon and the cecum. Biopsy taken from the edges of the ulcer was sent for CMV PCR analysis that showed positivity with almost more than 2 lakh copies per ml. TB gene expert was negative. So the diagnosis of IBD, ulcerative colitis, Mayo class 3, extent pancolitis with moderate to severe with CMV colitis was made. The patient was started on the patient was already on oral mesalamine treatment. He was also given mesalamine enema. He was previously on a higher dose of steroids. Dose of steroids was reduced to 10 mg OD. Antivirals valganciclovir was given at 900 mg BD for a total of 28 days. Patient was discharged and advised to follow up. After a month, he had significant clinical improvement with a drastic decrease in the perianal pain. There was no tenesmus and reduction in stool frequency was also noted with no bleeding PR. At present, he is on mesalamine therapy, both oral and rectal. And on follow-up, colonoscopy is planned for which he has, at the next visit, he has to return. So, CMV colitis, a few points. The prevalence of CMV infection in severe acute colitis is almost up to 21 to 34%. CMV infection in severe steroid refractory ulcerative colitis is almost 20 to 40%. The risk factors of CMV colitis in immunocompromised adults is mainly patients who are on long-term anti-cancer treatment, chemotherapy drugs, long-term immunosuppressions, patients with HIV. The main site of infection in immunocompromised adults is esophagus. Symptoms are non-specific like low-grade fever, weight loss, anorexia. In case of distal large bowel involvement, frequent small volume diarrhea is present. The endoscopic feature in 70 to 80% of cases is well-defined, pulged out ulcers as we had seen in our case. In immunocompetent adults, CMV is less common, but when it is present most commonly in the colon, and symptoms are usually of hematochezia, abdominal pain and diarrhea. The endoscopy will show discrete well-marked ulcerations without exudate in 50% of cases. Pseudomembranes can also be seen in 25% of cases. So in immunocompetent adults, the disease is usually self-limiting. All immunocompromised patients must be treated. Antiviral preferred is valganciclovir oral of 900 mg BD for a total duration of 3 to 6 weeks. If good clinical improvement is present within the first 1 week, a 4-week course may be sufficient. Going on to the second case. This was a 29-year-old software engineer from Pondicherry. He presented with complaints of loose stools for 5 to 6 weeks and fever on and off for 2 weeks. His loose stools, initially he had 5 to 10 episodes per day, which progressed to 15 to 20 episodes per day for the last 2 weeks. Small quantity, watery diarrhea with mucoid secretion. History of tenesmus was there with nocturnal episodes also. He had a diffuse vague abdominal pain, predominantly in the lower abdomen, lasting throughout the day. With no relation to food intake and relieved after passing stools. And history of fever for 2 weeks, which was high grade, intermittent, no diurnal variation, relieved by medications. No history of joint pain, skin rashes or oral ulcers. Past history, in 2017, he was diagnosed as IBD, Crohn's disease with pancolitis and was started on steroid therapy and mesalamine oral preparations. From August 2017 to September 2018, he had continued his treatment and had significant symptomatic relief. But in 2018, patient discontinued treatment due to some personal reasons for about 6 months. He did not follow up also. In that period, he had a flare with increase in stool frequency, pain and fever, and he was started on azathioprine and Viacelone, after which his symptoms receded. But then again, during the COVID pandemic from 2019, he failed to continue his treatment. On examination, he was found to be febrile. Per abdomen examination showed tenderness in the left lower quadrant. Investigation showed a total count of 25,480 with elevated ESR and CRP, and stool test for Clostridium difficile toxin A and GDH was positive. Cultures were negative. The tropical fever panel was also negative. On colonoscopy, the rectum and sigmoid showed mucosal erythema with absent vascular pattern with multiple linear ulcers, also with multiple yellow exudates and overlying slough with friability. So an impression of IBD Crohn's Mayo 3 was given. The endoscopy was, upper GI scopy was also done, which showed only antral erythema, and biopsy was taken. So the biopsy showed ulcerations, mild distortion of the architecture with cryptitis and cryptabscisses. Impression was active colitis, and UJ scopy also showed H. pylori associated chronic gastritis. For this patient, for the IBD, he was managed with oral and rectal mesalamine. His oral steroids were discontinued in view of his infection. For Clostridium difficile, a 7-day course of oral vancomycin and IV metronidazole was given. The patient showed improvement within a week and stool frequency subsided to 4 stools per day, no abdominal pain or fever. He was discharged on a further 7-day course of vancomycin and metronidazole. So a few points on C. diff. IBD itself is an independent risk factor for Clostridium difficile infection. Risk factors for developing C. diff among IBD patients is mainly use of antibiotics within the last 30 days. Cephalosporins, clindamycin have a more greater role than broad-spectrum penicillins or fluoroquinolones. Colonic involvement by use of biologics, mainly infliximab or adalimumab. There was no association between the use of mesalamine and steroids with the development of C. diff infection according to this meta-analysis published in 2019. Treatment for non-severe and severe C. diff infections, oral vancomycin is the drug of choice with 125 mg given 6th hourly, followed by oral fidaxomicin and metronidazole for a total of 10 to 14 days. In fulminant cases, adequate volume resuscitation, oral vancomycin along with parenteral metronidazole, and in patients with ileus, even vancomycin enemas are given. Fecal microbiota transplantation is considered in severe and fulminant C. diff infections. For first recurrence, we prefer a tapered or pulse dose vancomycin and fidaxomicin for patients who had initially taken a course of vancomycin or metronidazole. Adjunctive therapy is bezlotuzumab. This is a monoclonal antibody targeted against the toxin B of Clostridium difficile. This has also been tried and has shown good results in certain trials, this Modify 1 and Modify 2 trials. Second or third recurrence or subsequent recurrences is treated by fecal microbiota transplantation. Surgery is only in case of fulminant C. diff infections, a total colectomy with an end ileostomy or a diverting loop ileostomy with colonic lavage is preferred. That depends upon the clinical circumstances and the surgeon's choice also. Thank you.
Thank you. A poignant remember of IBD plus. So even though the patients come with what sounds like flare, so you should keep an open. In the first instance, the classic ulcers, and the second time, what our teachers say, bundi appearance, that yellowish deposits in the mucosa. It's open for discussion.
What was the diagnosis in the duodenum, madam? First case. There were lesions in the duodenum.
Yes, sir. There was a granular mucosa. We had initially thought that duodenum lesion is because of CMV itself, sir. CMV colitis can also affect the duodenum and upper intestine. Histopathology did not pick up any CMV specific features in the duodenum, sir. We had particularly asked for that. The cytopathological changes were not there, but erosions and those cryptitis, and they said it could be related to CMV.
Eosinophils were there. Significant eosinophils were there.
No. See, Crohn's, it can affect duodenum upper GI, but as a ruled out Crohn's?
It looked more like a CMV infection of the duodenum than a Crohn's at that point. We had taken CMV PCR only from the rectal ulcer. It could have involved the rest of the intestine also.
Histopathology did not show classic CMV changes, cytopathic changes, but we picked up the CMV infection, though it was strongly suspected because of the pattern. Not very important. What is that it manifests like a inflammation rather than cytopathic change. So we attributed this to probably generalized CMV involvement because he was very sick.
Thank you, Doctor. Thank you. Invite the next presenter, Dr. Dinu Abhirami, poem for failed LS myotomy.
Good evening, everyone. So, for today's discussion, there is a case of post-Heller's myotomy with the recurrent symptoms and role of poem in such a patient. So, our patient was a 35-year-old gentleman with no other comorbidities. He was having symptoms, that is primary symptoms started in 2017 with the progressive dysphagia, regurgitation, and the symptom worsened by around 2020. When he came for evaluation, this evaluation was done elsewhere, and he was diagnosed to have achalasia cardia type 2. And for that, he was suggested a lap Heller's myotomy, and in September 2020, he underwent a laparoscopic Heller's myotomy along with fundoplication, Taupers fundoplication. And for the initial 3 months, he had a better symptom improvement, and he was doing well. So after 3 months, he had a recurrence of symptoms, again progressive dysphagia, and when he presented to us, he complained of dysphagia to each meal with associated retrosternal discomfort, and there was no history of regurgitation with a weight loss of 4 kg. So his ECA score we calculated was 5, and otherwise his clinical examination was normal. So this is the endoscopy we did initially. So as we could see, there is pooling of saliva in the esophagus, and as we move lower down, we can't visualize any contractions in the esophagus, and at the distal end, that is just above the OG junction, after a thorough wash, we could make out a outpouching at just above the OG junction. So the OG junction was at 41 centimeters from the incisor, and this was the outpouching seen just above the OGJ. And while passing the scope, there was still a resistance felt at the esophagogastric junction. Next slide. So we suggested a repeat manometry for this patient. So this body showed absent peristalsis with the panesophageal pressurization in 20% swallows, and the IRP was still elevated to 19.2. After nifedipine, sublingual nifedipine, the IRP reduced to 12.8. So a conclusion of persistent type 2 achalasia was made. We also did a time barium swallow. At 5 minutes, there was still stasis of barium in the esophagus, and we could make out that saccular dilatation just above the OGJ. So we considered all treatment options for this patient. This is a review article published in Digestive Endoscopy Journal in 2021. This has suggested that if failed initial treatment, then we have to objectively confirm the failure with the manometry, time barium esophagram, and endoscopy. And if the patient is still suitable for a next procedure, then we have to offer them the second procedure. So all these treatment options were considered in this patient: pharmacotherapy, pneumatic balloon dilatation, POEM, and repeat Heller's myotomy. So our patient, he was discussed all the pros and cons of all these things, and he wanted a permanent solution. Pharmacotherapy was only a short time relief. Pneumatic balloon dilatation might need a repeat procedure. We also explained about POEM and repeat Heller's myotomy. Patient wanted to go in for a POEM procedure. So this is the procedure video. So this is the pseudodiverticulum noted above the OGJ. Submucosal incision was, cushion was raised and the incision was made at 31 centimeters. A submucosal tunneling was done up to the OG junction. While tunneling, we could make out the perforators, and as we went down the tunnel, we could make out the spindle vessels. This after we reached 41 centimeters, we wanted to doubly confirm whether we have reached the OGJ, because to have a complete myotomy this time. A double scope technique was used, and position of the tunnel up to the OGJ was confirmed. And myotomy was started at 33 centimeters and it was extended 2 centimeters below the OGJ, that is up to 43 centimeters. So during the myotomy, we could also make out the previous fundoplication, that wrap was visible, and the myotomy was extended down up to 43 centimeters. This is the wrap appearing. We could see the difference, and beyond that we extended the myotomy, and this is the pad of fat which is visible. This is the tunnel at the end of myotomy. After completion of myotomy, we have inspected the tunnel for a complete hemostasis, and this is the distal end of the myotomy, and after that we have assessed the OGJ, which was now loose, and there was no resistance felt at the OGJ while passing the scope. And after this, mucosal incision was closed with the hemoclips. 4 hemoclips were applied. So immediate post-procedure period was uneventful. He was done a repeat barium swallow, which revealed no stasis of barium, and he was started on oral liquid diet, and he was discharged on day 4. So patient came for follow-up with us after 1 month of the POEM. He is still asymptomatic, and repeat endoscopy was done, which showed this healed mucosal incision, and this OGJ was having a 5 centimeter small erosion just above the OG junction. Otherwise, the fundoplication wrap was also noted. So this is the time barium swallow at 1 month of follow-up. He is currently tolerating a normal diet, and he is still asymptomatic and is on follow-up. So this is the HREM done after 1 month of at the time of 1 month of follow-up. Now the IRP is normal with no pan pressurization, and it is suggestive of an adequate response to myotomy. So just a few literature review on what is the treatment options available in a patient with who underwent a Heller's myotomy for achalasia. So what is the role of POEM in post-Heller's myotomy recurrence? This is a review article published in 2021 in the Annals of Gastroenterology. This is actually a meta-analysis which has included 11 studies, out of which 303 patients were included, and this has also done a comparative analysis with and without prior Heller's myotomy. So if we see the overall clinical success rate of POEM is 87% in post-Heller's myotomy patients, and the technical success rate was almost 97%. So major adverse events, only 5%, with the new onset GERD noted in almost 33%, and esophagitis in 38%. So from this study, they have suggested that POEM is also a safe and effective mode of treatment in patients with failed Heller's myotomy, and it should be considered in patients with recurrent achalasia. So outcomes of POEM are comparable, that is clinical success rate and technical success rate were comparable with and without prior Heller's myotomy. So what is the cause for recurrence after a Heller's myotomy? Most commonly it is an incomplete myotomy, and the other causes which have been postulated are periesophageal scarring following a surgery, or an GERD post myotomy resulting in acid reflux and peptic strictures, or an obstructing tight wrap, that is a fundoplication. And in few patients it could be an end-stage achalasia. So there is another entity in our patient that is a blown out myotomy, that is the saccular dilatation we visualized just above the OGJ. So when do we call it a blown out myotomy? It is actually when the In a radiological investigation, if the diameter of the esophagus is more than 50% at one point, when compared to the rest of the esophagus, and that is at the site of myotomy, when compared to the rest of the esophagus, it is called as blown out myotomy. So the risk factors for this blown out myotomy are pre-treatment type 3 achalasia or an LHM, if it's more found in post-HELLAS than POEM, and a greater post-op treatment IRP. So this study has included 139 patients, out of which the incidence of blown out myotomy was almost 17.8%. And when compared to POEM, the rate of blown out myotomy was higher with LHM. So this is the mechanism behind development of LHM. As we could see from C to E, after a myotomy, that area of the esophageal mucosa becomes lax, that is, there is no muscle supporting it. So, and whenever there is still persistent high lower esophageal pressures, so the esophagus, when trying to push the food, will have a saccular dilatation at that point alone, resulting in a blown out myotomy. So to summarize our case, after HELLAS myotomy, the recurrence of symptoms incidence rate is around 10 to 20%. The most common cause is an incomplete myotomy, followed by periesophageal scarring, acid reflux peptic strictures, and obstructing tight fundoplication. So there is no consensus guidelines on what are the therapeutic options to be followed after a failed primary procedure, that is rescue treatment, what is to be followed. Treatment options which can be done are rheumatic dilatation, a POEM, or a redo HELLAS myotomy. And also in such patients with the recurrence, dietary and lifestyle modification do play a role, and always a multidisciplinary team discussion and individualized treatment, that is patient to patient variation of treatment, that is one size fits all doesn't apply to recurrent symptoms patient. So blown out myotomy is a novel entity which we came to know after this case. Thank you.
Good presentation, Dr. Dinu. It's open for discussion.
Dr. Mohan Prasad, so congrats for introducing a new term. I never knew about blown out myotomy. It's a new term to me. Thank you so much. And my question is on, do we have a manometry before surgery? Did the surgeons do a manometry or HREM, or straight away they took for surgery?
Actually, the pre-surgical records patient has lost. We couldn't get that.
Okay.
But he told that he was done a manometry.
Okay, wow. So one situation is if it is type 3 achalasia, then this sort of a problem can arise if there is an incomplete myotomy, because lap HELLAS, they have to pull the esophagus down and then have to do a myotomy. Sometimes it may not be enough if the pressures are very high. So that is where our POEM scores over. One advantage for POEM is HELLAS is anterior approach, and majority of us use the posterior approach. So we find it convenient. We have completed 50 cases. Posterior seems to be easy for us to drive rather than go anterior. So, but if you're doing a plication, then anterior approach is required, just like what the surgeons do. If you go out of the, the OGJ and then, try to oppose the stomach, then it might work. Probably this one was either an incomplete or was a type 3 achalasia initially, and then has shown this. So, and about the previous case also, if you would permit me, I'll take a second. Just about the C. diff infection that was beautifully pointed out in IBD. So we do see on and off, but in normal healthy adults, we don't see C. diff. I had a patient who was there in the US, almost 25 years back. And this was a youngster. He had 3 life-threatening episodes of C. diff infection and treated with so many drugs, including vancomycin, metronidazole, all that. Finally, he decided to move back to India. So he used to be in touch with me all the time. It is now 20 years since he came to India, to Coimbatore. He's a industrialist. Not even one episode of C. diff infection. So which obviously shows the type of diet we take and also the bacterial flora that we have. Probably, healthy, non-immunocompromised individuals, we don't see much of C. diff. So I just want the floor to respond, like, do you see in non-immunocompromised healthy adults also C. diff do you pick up in Tamil Nadu?
So, thank you, Doctor. The organizers have said we need to move on to the next agenda for which we are mainly assembled.
Thank you, sir.
Thank you, sir. I know, in fact, it is a sad moment for all of us. I find these lines, I think no one can replace. Life without you to guide, coach, instruct, and provide stability to this organization. I don't find anybody who is apt for the name in this set of 450 members. I think it is one of the difficult person to replace. Because even when Malati Madam wrote in the journal GHEP, he mentioned the word Balasar Solitar. That Balasar Solitar is like a mantra to everyone. So if he says something that is no one can resist or refuse, or it is invariably it is that kind of magic word. It is so much love in that, and not only love, that some kind of order will be there. That the term will have that effect to everyone. Whoever it is, I think that Balasar Solitar and word is a mantra. I think I don't find anyone can replace that Balasar Solitar. So I have shared some of the few messages we came, and few photos. Next slide, please. Some of the photos shared by Professor Jayanti. Next slide. This is one of the meeting with Jayanti and Gurdas Chaudhary. Next slide. Next slide. So yeah, I know this is the first meeting I think Balasar is without us. In fact, before 1 week we had a Zoom meeting, and he was there on the Zoom. That is one of our governing council meeting on the Zoom, and he was there. And next Monday he was no more. Next slide, please. So this is a 2019 TNIG in Chennai, I think. Next slide. This is a Kanyakumari midterm meeting. Next slide. And this is the this is the MWGO stars with all the stars. Next slide. Next slide, please. So this is from Dr. Krishnan, who is not able to join. He said, this is what I wrote in when he was died. Bala sir, who breathed TNA chapter, had breath his last. He also mentioned on Kural, Tunga Tungi Sailbada, Tungarka Tunga the Saimbinai. That means the aggressive action, whenever it is feasible, is good. Where it is not likely to be successful, try other means to try attain your object. So he also said a consummate strategist, rare among the medical professionals. He believed in the maximum many miles to go. This is from Dr. Krishna. Next slide. This is from Dr. Gurdas Chowdhury. He said, deeply shocked at losing Bala. My heartfelt condolence to all my friends and colleagues at the loss of Bala, dear friend of many years. His passion and zeal for the ISG chapter of ISG was admirable. We'll miss him deeply. Pray for his soul. Please convey my feelings to his family. Next slide. This is from Shyam Varadarajulu. Actually he's coming next week. Bala was a very great soul and we will all miss him very, very dearly. It is hard to imagine going to the residency towers without him. He owned that place. Kindest and personal regards. Next slide. This is some of the slides shared by Dr. Malti Madam. Next slide. Next slide. Next slide. Next one. Next one. Which one, madam? Previous one. Okay. Next slide. And this is the Silver Jubilee meeting. Yeah, same hotel. Yeah.
Yeah, the same hotel in the stairs that you came across. Yeah, the same place. You can see him standing there next to Dr. Ramar. Dr. Ramar, you're there. Yeah, yeah. Yeah, yeah. All of us are there.
Next slide. So I request all the members to offer the condolence. I request the first Dr. Muhammad Ali, because he's a beloved student, and I know most of the presidents and treasurers as very secretaries has very good understanding with Bala sir. I think Muhammad Ali sir is the first one to carry out the resurgent TNIG again. I request Muhammad Ali sir to offer the condolences.
Dear friends and colleagues, I was shocked, grief-struck, and collapsed when I heard the news about the tragic, sudden, and untimely death of my beloved teacher, Professor V. Balasubramaniam. We used to call him VBS. I hereby offer my tribute to this great teacher. My association with Dr. Bala has been for many decades, starting off when I joined as a postgraduate in the gastroenterology department at MMC, wherein we had professors like Professor Raja Sambandam, Professor Raghuram, who is here, Professor Ramatilagam. They were all our professors, but as you all know, we have more freedom with our assistant professors. And Bala was there, who made us comfortable when we entered the department. He was always composed, polite, and a true gentleman who respected everyone. He went about his course with a smiling face, and he always told us, please learn clinical skills. And this is what he always insisted on when we joined the department. And he said he had imbibed this from the great doyen of medical gastroenterology, Professor N. Madanagopalan. He had a great passion for teaching and was gifted with the knack of carrying along even with those who disliked him. Incidentally, there were very few people who disliked him. And ultimately, they also became his fans. Be it undergraduates, postgraduates, junior consultants, senior consultants, all were attracted towards him like a magnet because he was always able to solve their problems very cleanly, and they all went away with a smile. At DDHD, Anna Nagar, under Professor Dr. Subhash, the department became a premier center for doing therapeutic gastroenterology work. But then it was Bala sir who single-handedly managed the sea of patients in the OP. And he asked all of us to go and join Professor Subhash to do the therapeutic work because he was taking care of the patients. Just imagine if we were also taking care of the patients, we may not have done so much of therapy there. He was instrumental along with Professor KRP in reviving the Tamil Nadu chapter of the Indian Society of Gastroenterology, and deservedly he was made a patron for the society. He shot to national fame after he successfully organized the midterm as well as the annual ISG conferences, and following that, he motivated all the senior gastroenterologists to form a Tamil Nadu Gastroenterology Trust, which is very unique only to our state. Apart from doing all the various activities, the trust also has been sponsoring the journal GHEP. When I took over as secretary in 2007, sir told me, "Bye," that is how he used to call me, "please arrange 2 seminars in our society. What gastroenterologists, gastrosurgeons should know about medical gastroenterology, and what medical gastroenterologists should know about gastrosurgery." This was a great success. In those days, we used to have our meetings on a Saturday afternoon, starting off with lunch, followed by the seminar, and then it will end up with tea around about 4 or 4:30. But these 2 sessions were so lengthy, we almost landed up beyond 6 o'clock. But it was very well taken, and we found that the halls were completely full even at 6 o'clock. So some of them were telling, "Why don't you give us dinner also at the end of this session?" But it was a great take for all the gastroenterologists at that time. He made his life as exuberant and effervescent as possible by jeopardizing envy, hatred, pride, ego, and left behind footprints on the sands of time to become a legend and icon for all of us to emulate, though it's very difficult, I think so. He, along with Dr. KRP, were the backbones of our society, but he alone undisputedly was the live wire, and the void left behind, I don't think can be replaced. He was a very passionate person, much attached to his wife and 2 children. I think he must have had a premonition about this tragic event just a few months back. He called me to be a witness for the will he had drafted. He lived life full with a purpose to serve humanity in spite of all his physical disabilities. But as you know, man is helpless before the Almighty, and though cruel death has separated him from all of us, he will ever remain fresh in our hearts and memories. I hereby offer my heartfelt condolences to his family and pray to the Almighty to give them strength to bear the irreparable loss. Rest in peace. A heartfelt tribute from a beloved and obedient student. Thank you.
Thank you, sir. As sir said, without him, Professor Palaniswamy will have found it very difficult to run this society. I think I request Professor Palanisam to offer and give the condolence.
I am very sad to stand in front of you to share my journey in the field of gastroenterology along with Dr. Bala. In fact, just when I crossed Jayanti, Dr. Jayanti told me the chair next to you is empty. Always in every meeting, we used to sit always together. So this chair will be empty forever. I am very sad about it. My journey with Bala started many decades ago. In fact, Dr. Bala was my 1 year junior to me in general medicine when I was in Madras Medical College. And subsequently, of course, he joined gastroenterology much later. My association started building up from 2003. That's when we organized the annual conference of gastroenterology. And you can see this photograph. Of course, I'll share some of the memories of the photographs. I think that probably will be able to appreciate our association. Next. And these are the few slides about the national conference which I organized in 2003. This is a landmark meeting. Even today it is talked about, where people talk about the meeting. In fact, when I decided to organize this meeting, when from Tamil Nadu chapter we bid and got the conference to Chennai, and then it called for a meeting of our colleagues to form a committee. So then, of course, even though Bala, I knew him before that, but still my association was not very close. So voluntarily, Dr. Bala came to me and he said, probably he offered his help to organize the meeting. And then almost now, with this close association, he became the joint secretary. And without him, I don't think I would have been able to sort of conduct the conference in such a big manner. In fact, that was a 5-day conference. 5-day conference went flawless. Those days, we didn't have a computer. All those, the slide projections or the carousels and the slides and the time management, everything went perfect. And one more thing I would like to share. And in fact, when we were discussing various aspects of the conference, and that was the first time in any of the meeting we gave a briefcase with all this. We usually give a lot of contents in that. I would like to share, we gave the menu card. Menu card was prepared for all 5 days, dinner, lunch, dinner, everything, and put in the bag. I don't think it was done before or now anything. I don't think any of the big meetings done. That was mainly because it was possible because of Dr. Bala's involvement. And in fact, Dr. Bala controlled the whole meeting, and he was the event manager. And he was sitting in there was a small manager's room. He was, as your Dr. Ali mentioned, he could command anything. That was possible because of Bala. And then in that conference, we brought out ISG, that is the CME manual. CME manual, I don't think today's conferences, nobody brings out CME manual. The CME manual was brought on time. It was issued on the day of CME in the morning. That was possible because of Bala's active sort of a participation, actually help. Otherwise, I don't think it could have been possible. The other thing is souvenir. I don't think many of our youngsters will know what is souvenir, why souvenir is sort of being brought out. Souvenir those days, because these days you get good support from Pharma. We don't think of any sort of there's no monetary issues. Those days, we have to generate money. Pharma companies were supporting, but not enough. So we bring out souvenir to generate money with advertisements. So in 2003, we could get nearly more than 15 lakhs with the ads alone. Of course, that was again with great support. Although, of course, I was instrumental in getting all the support in the industry, but without Dr. Bala, I don't think I would have done this. And when the most important thing is Dr. Bala brought one PRO, on Mr. Venkat. Mr. Venkat was Dr. Bala's classmate's husband. He was, in fact, a strong person. He helped us in a great way. He continued his association at many more meetings. Next. This was the inaugural function of the meeting where the then health minister was there. And you can see this. And then I would like to share this subsequently. When I was the president-elect of the Indian Society of Gastroenterology, 2004, and as a president-elect, you have to conduct the elections. These days, of course, now holding an election is very easy because now you can just electronically vote. And those days, we have to get, send ask for nominations, send the ballot papers, and get the ballot papers and do the counting. And countings are done either in your place, or you have to carry the ballot boxes and go to the venue the day before the conference, count the election and the votes. And this year, the problem was one of the sort of like one person who could contest it, his initial was wrongly mentioned. So he said, no, they have to call for the papers again. No, we have to resend everything to all the members and got all the ballot papers and counted here. This counting, you can see this was organized in Hotel Palm Grove, and this whole thing was organized by Dr. Bala. You can see Dr. Bala, Dr. Krishna and me. Can I move the slide? Next. And this was the result. This way the result was announced during the conference. Of course, Dr. Ashok Chauko was one of the successful person for the governing council. Next. And Tamil Nadu chapter, as Dr. Ali mentioned, Tamil Nadu chapter was again rejuvenated by, of course, both of us, the May and Dr. Bala. And today it has grown to this level because of the strong association and the motivation by Dr. Bala. Without Bala, I don't think it would have moved to this level. And of course, as Dr. Ali said, started with Dr. Ali and subsequently many other secretaries were there. Now, with the active involvement of Dr. Baldus, it has now grown to really great heights, not only in the CMEs and active meetings, and the active participation of prescribers are all possible because of the involvement by Dr. Baldus. And of course, the Jammu Nadu chapter, we have the annual meetings, monthly meetings, midterm meetings, and we had the rural meetings, and we had several public awareness programs, public interactions were done with the Tamil Nadu chapter. And also the PG activities now, of course, you're all experiencing that now. And like travel grants were given, research support, and also for the library. Next. And this, the ISG is a part of the Indian Society of Gastroenterology, Tamil Nadu chapter. When I was the president of the ISG, I had to hold a midterm meeting. This midterm meeting was held in Ooty, and this was a 2-day meeting. This meeting, again, this was only case-based discussion. 2 days we went on flawlessly, and with all the, not only the academics and all the social evenings went on beautifully with Dr. Bala's help. Next. This was the governing council in Ooty. And the next important, and before this, in 2011, the again annual meeting of the Indian Society of Gastroenterology conference was held in Coimbatore by Dr. Mohan Prasad. In fact, that particular year, the annual conference was supposed to have been held in JNK. It was had to be cancelled because of the terror activities. And they were wondering who will take up this conference, because the time was short. Mohan Prasad took up the challenge, and then of course Bala was the backbone. Without Bala's support, I don't think we could have successfully held the meeting. And then subsequently, as Dr. Ali mentioned, we formed a trust, and this trust formation was the idea of Dr. Bala. He said this formation of trust was possible with the money saved from the annual meeting which we held in 2003. We formed the trust. With the formation of trust, we held a lot of the activities like several international, national meetings, PG activities. I'll just share with you some pictures. And this was a program, it's called Train the Trainer. For many of you, if you are not aware of this program, I'll just briefly mention what is this Train the Trainer. This is held by World Gastroenterology Organization anywhere in the world annually. And this meeting was held here in Chennai in 2011. And I went as a participant for this meeting. Each country can send 2 participants per year. And that particular year, myself and Dr. Randir Sood went as a participant to Croatia. So here, this meeting, this is a four-day in-house meeting. See, generally, suppose we are holding, host country can have 25 participants, and internationally you will have 25 participants. There will be 10 faculty from international faculty, plus a couple of international faculty will be there. This is about 18 teaching and training modules. They will give projects you have to present. And apart from the academic activities, there will be team building events and also the social evenings. So this is the format of this meeting. In fact, and also for the social evening, you have to perform yourself. Each country, you have to perform. You can't give a presentation, the PowerPoint presentation. I was wondering what to do when I was going to Croatia. I talked to Randir, so what should we do? Randir said that he'll talk about the country and then the personalities of the country. And then I was wondering what, I was talking to Bala. Then he said, why don't you sort of go as a Mahakavi Bharatiyar, and then probably with the attire you can go and just go to the. Then I was I talked to him, Mahakavi Bharatiyar may not be about, maybe we can think about Swami Vivekananda. So immediately he organized the attire. He called a makeup man from a movie, and he organized a Swami Vivekananda attire to me. And in the meeting, and as Randir Sood talked about these personalities in our country, he talked about Swami Vivekananda. Then he said, here comes Swami Vivekananda. I went with that attire, and it was a great success, and talked about the few words which he talked in Chicago meeting. And this was the train-to-train meeting held in Chennai, and he was the Secretary General. Next move. These were the participants in Chennai. This is the 25 international, 25 national, and of course all the faculty. I think some of you who participated, TSC and many others, and Pramanayagam, they're all here. Next. And here, as I told you, there's a team building event, and we have to organize a cultural evening and also sport evening. The sport evening, and then I was discussing with Bala, what should we do? Then he said immediately, he called Mr. Venkat, who was his PRO also. Venkat's son-in-law was the physical director, and we organized this event, football event, in World University Service grounds. And it was a serious football event, and we had 4 casualties at the event, at the end of the football game. One person from South America, he had a blackout, and we had to take him to Apollo Hospital, do all MRI, and I think fortunately he got well. One Kerala doctor, he had sustained a fracture. Other person sustained all minor injuries. These were all these things with all Dr. Bala's support, we could manage. And then this next picture you can see, this was when we held this meeting, Train the Trainer in Chennai, our contingent, Indian contingent performed, and they had this thing. You can see the picture, Dr. Ashok Chako as a father, and then even at TSC, I think he wore a dhoti and a shirt, and it was a very interesting presentation. Next. The next one was the international, that is the US World Congress, which was held in 2014. And when Dr. Shyam, of course, we organized several programs for the endosonography, that is meetings as well as the live transmissions, and we held an animal workshop also with the live pigs in the veterinary college. All these things were possible. With all the events where we had a very good support from Bala. Without that, I don't think it could have been possible. As this thing, then Shyam Varadarajalu asked me whether it is possible to hold a World Congress on endosono. And it's a big event. It happens once in 2 years somewhere in the world. And it was a challenge. And then that time, we were wondering, should we take it up? Then I was talking to Bala. He said he agreed. He said, we'll take up a challenge. And here, this was a 2-day program with the lectures and also the live transmission. And this is a very good program, went minute to minute, and beautiful program. And we had about 50 international faculty and 200 international participants, about 500 our national participants. That's all it was possible. And one more important thing I want to mention, whenever we organize a conference, of course we have to collect funds from pharma. And Bala is very strong in this. And before the conference, before we start the conference, he makes it a point to collect the money. That is a policy. Always, that's always, even till the last meeting, he did that. And the other important thing is, after the conference is over, before he leaves the hotel, the account will be settled. So maintaining the accounts, settling accounts, and also discussing with the hotel people, bargaining with people, I don't think anybody else can do it. Next. The next meeting was the International IBD. It was held in Chennai in 2017. That was again a 2-day meeting. There was a very good meeting conducted. This again, Dr. Bala's active involvement helped us. Next. And then apart from these meetings, we have held several camps, village camps. I think many of our colleagues who participated in the camp, Dr. Venkatakrishnan, Mohan Prasad, are all here. And here we do the free service, free camps, and we did endoscopy, gastroscopy, colonoscopy, ultrasound, everything free, and distributed drugs also for 2 months. And we held about 8 such programs. Of course, because of Bala's health reasons, he couldn't come for all the meetings, but he did come once. And even though he was not physically present, and he was the main man, he was following every step of the meeting, used to follow closely. Next. And also, we used to have a public interaction with the villagers. One such meeting when Bala came, he interacted with the villagers, and villagers in fact enjoyed Dr. Bala's interaction with them. He can communicate very nicely with people. And the next important event we held with under the banner of Trust is the patient interaction programs for the IBD. We held about 2 physical events and 2 virtual events. During the COVID, we did a virtual events. All these programs, of course, were physical meetings. Dr. Bala did participate in one of the meetings. Virtual meeting, even during the COVID period, I think Dr. Bala participated in all the meetings. I don't think any other meeting he missed till the end. Next. Of course, GHAP journal, the initiative of the trust again. And this, of course, this concept, this was initiated by, I think, Dr. Ipan, Dr. Baldus. They discussed in one of the ISG conferences. They brought out this idea. And when we were discussing how to go about it, then ISG said the Tamil Nadu, individual chapters cannot run a journal. Then probably decided we'll run it under the banner, under the trust banner. Now 2 years, I think it's been we had a successful period, and we did celebrate the 2nd anniversary. And I think you will all experience the contents and the importance of the journal. Next. So, Dr. Bala's attributes, I think Dr. Ali did mention many of his qualities. And here, if you look up, he has a helping tendency. Anything, any help, not only in related to your medical field, even any personal help. If you say that, just tell Bala, it will be done. So that was Bala. And next is very humble. So that's an important character he had. And he was very compassionate. And any problem, any crisis, he will solve. That's the most important thing. And he can handle crisis, emergent situations. Many of even when I had some personal issues, personal problems, he did help me, which really benefited me a lot. And he's a great friend. I don't think anybody can replace him. I don't know how to find a replacement. The chair next to me will be always empty. Next. So I would request all of you to carry his legacy forward, and future generations should get actively involved in clinical gastroenterology. Dr. Ali mentioned he always believes in clinical medicine, clinical gastroenterology. Today we miss. We treat patients from a distance. We don't go close to the patient. We don't talk to them. we don't examine them. If there is a concern, who will teach the next generation how to palpate the abdomen? Really, I'm really serious about it. And of course, academics and research, you should carry forward. Of course, now with the active these programs by ISG now, with the tenure of Dr. Baldus, really it has come to this sort of a level academically. Next. Truly great friends are hard to find, difficult to leave, and impossible to forget. It's very difficult to forget Dr. Bala. I would really, I will probably pray for him, and heartfelt condolences to the family. Thank you.
Thank you, sir. I request Dr. Ramar, his classmate and friend, to offer the floral tribute and condolence.
I am standing before all of you as a gastroenterologist because it is Bala who helped me with that. I am privileged to have him as my classmate in DM gastroenterology. We shared together about 3,200 hours. For example, 8 hours in a day, 20 months in a year, then you calculate that comes to 3,000 and odd hours. So he's a very nice person, very jovial person. I had my own personal issues in continuing the postgraduate course, DM course, because my family was, I was living in Kanjipuram, some 75 kilometers from this Chennai, and daily used to travel by bus. You have to come to the department at around 8 a.m., leave by 4:30 or 4. The period was very tough for postgraduates during those period. And only 2 candidates, the whole of Tamil Nadu. We were the only 2 candidates. Those days, no other colleges had a DM gastroenterology course. So I was 46 years old when I joined the course. He was a bit younger than me, 4 and 5 years younger than me. Well, many times I thought of discontinuing the course because of tedious travel and so many other factors. But he helped me to tide over the crisis on each and every occasion. That is why he enabled me to complete the course and become a gastroenterologist. So I happened to learn the death of Bala through the newspaper. That newspaper advertisement newspaper came in the Hindu, I think 3 days after his death. I was shocked to see him. Then I told my wife, and I don't know what to do, I don't have any contacts. So I got hold of Dr. Badmanabhan. He helped me in telling all the recent happenings in his life, underwent surgery and all those things. Of course, I was not in touch with him because many months I was not in abroad. I'll be in abroad, so no touch. So it's very difficult for me to digest his death. It is a premature death. He helped me a lot. And very jovial and very funny, and we shared so many funny moments, funny things. And I enjoyed his, very difficult to accept his premature death. So I wish the family, everything, to tide over the tragedy and become stronger. Thank you.
Our President Mahesh Kumar Goenka is on the Zoom link, and he will offer his condolences. Sir, you are not audible, sir.
I offer the condolences to the memory of Dr. Bala Subramaniam. We heard all the details of his activities from Dr. Palaniswamy, and whenever in my younger days I used to think about anything being done in Chennai, the two names which used to come all the time was Dr. Palaniswamy along with Dr. Bala Subramaniam. I think they were a duo who could do anything, could perform any activity in Chennai in those years. We already heard what all he has contributed to the science, to gastroenterology and to the society, whether it's the Tamil Nadu chapter or the National Society. I have interacted with him only during various annual conferences, and if I have to summarize, I found him to be energetic. I think his energy was infectious. I found him to be very interactive. He would be the one who would ask possibly maximum number of questions to the speakers. And I found him very organized. As Dr. Palaniswamy said, he was a very organized person and would leave no loose ends in any activity. My last interaction was through a digital platform only last year during the COVID. Tamil Nadu chapter organized a meeting and I was the speaker and Dr. Bala was there. And I remember that at the end of the meeting I told that we need more members from Tamil Nadu. And he just told me that just send me a letter and you will see that a huge number of members will be added from Tamil Nadu chapter. That was his confidence and that was his energy. We would miss him, and I don't want to be repetitive, but I must say that I wish we had more time with him during various academic activities. We would definitely discuss his contribution in the next governing council, which will be held in Jaipur, and would see to it that he is honored by the National Society in the proper form. With that, my condolences to the family, friends, his students, his colleagues, and all of you. Thank you.
Thank you, sir. Next, I call upon our senior members, Dr. Raghuram, sir. Please offer.
It's a really sad affair, sad state of affairs, because he was my MD student, he was my DM student, and he was my colleague. And he used to be of immense help. Anybody said anything, I used to call him, Raghuram sir, it's done. This things, only thing he said, it is done, don't worry. Nothing, he will have the work done at any cost. And as everybody said, Tamil Nadu is in the chapter of gastroenterology is standing before you like this is because of that single person. Of course, money came through Palanisamy and other means, mainly by the gain we got from the annual conference of ISD here. This is the first time in the Indian Society of Gastroenterology chapters, this amount of money was came and we deposited in money and made a trust out of it. Never, all these years, I've been attending for more than 40 years, nobody has created a trust with the gain they obtained from the, apart from contributing to the national trust, national society. So anyhow, he was the backbone for all these activities. Anything, he will get it done. There's no question of not getting done in him. But I really miss him, and I used to feel tragic. 6-footer has become a 4-footer. Handsome personality, and he developed rheumatoid arthritis. When he developed first knee pain, he came to me, sir, they are saying it could be rheumatoid arthritis. At that time, only big joint involvement is very rare in rheumatoid arthritis. So, orthopedic surgeon, he is no more. He said it was single joint pain can be due to rheumatoid arthritis. Within a span of 6 months, he developed entire thing. It became short, and in spite of it, he used to attend all the conferences. Even coming in wheelchair, he used to organize the conferences. It's really very sad. I thought even for the past 1 year he was withdrawn. He was not at all coming. I asked him, sir, Parvala sir, it's all right, what is there? I am still there, I am doing things. He used to tell me like that. KR sir, he used to call me KR sir, I just can't forget him. He is a pillar of strength to all of us, be seniors or juniors, but we have lost a great soul, suddenly, that too suddenly. May his soul rest in peace. My heartfelt condolences to the family members. Thank you.
Thank you, sir. Dr. Jayanti, madam.
It is a rather sad day. Sitting at the back, Malti and I would always find one glowing head, and then we'd find one other person with a full cupped head. And that chair would always be occupied by Dr. Bala. And as Dr. KRP said, I think that seat should always be kept vacant, sir. So we believe that he's sitting there. Okay, so my first encounter with sir was when we were in DDHD, Malti and myself. He was a postgraduate, and he would come to us for classes. That was my first encounter with him. And then after that, he always regarded me as his teacher, so that continued for quite some time. And later, I don't know which year, but he came as assistant professor to DDHD. And Malti and I, and we were 3 of us together there. And, he'll have one big bracelet, it would be just about almost 1 inch thick, And I think en kannadam patturthu nenikren. Because every time he would swing, he said, sir, enna sir, engalukla ippo kudukka poringa, no? And lo and behold, within 6 months or so, he had to take off the bracelet. And I said, oh damn thing, what did I tell that this happened? And that was the time when he started getting the joint pain. And I think then we worked on together, and then I went to UK, and I don't remember what exactly that point of time. And of course, he'd always call me Jayanti Ma, and he has his own way of telling. Whatever he would say, he would ensure that it's done. He'll say that company is called, you have to give a talk on IBS, and there was no question of saying no to that. So that was him. And the other thing was that there's so many things to say. Just to make it short, last few months was missing. And I kept on asking Dr. KRP, why is he not there? He just said he's unwell. Then I said, 5th of December, we were together in Delhi. I said, I have to go and meet him. I know his address. He says, no, you talk to him on the phone. He's willing to accept you on the phone. And I think after that it was too fast. I did not have a chance to speak to him. And the rest was history. So I think whatever time we had with him was something phenomenal. He would always be with us, and I'm sure he'll be seeing us from wherever he is, and I'm sure whatever he's carried forward and whatever he's entrusted to us, I think we'll carry on. And one interesting thing, when Dr. George Kurian came for the meeting, we were taking photographs with GK and myself and Malti. He called up next day, he said, Jayanti, you're looking very beautiful. I said, lo and behold, what is this? Suddenly he's saying this, I said, what are you talking, sir? I came straight from the hospital, not even dressed up properly. No, you're looking very nice and beautiful compared to your friend, that's Malti. So I said, thank you very much, sir. That was the last dialogue I had with him. So I think all the memories will be always with us. He was a great friend, and one thing I forgot, after dinner, I'll go to that there'll be one particular table with I don't know what they have in the hand, Dr. KRP and Dr. Bala. And all the snacks from the hotel will come to that table. The entire snacks, the best snacks would be in that particular table. And I'll finish my dinner, Jayanti, Vama, Ella Odakirku, and I'll sit with them. That I'll miss, sir. So I think I'll join you for that particular snacks. And probably we'll have someone else to help you to be with us, and we'll continue with that. May his soul rest in peace, and heartfelt condolences to his family members.
Thank you, madam. Rajnikant sir.
Be brief. I first met Bala in 1991 when I joined DM for my second innings at a ripe old age of 45. I thought I was the oldest, but Ramar beats me to that. And Bala quickly understood my plight, my age, my difficulties, and he was so compassionate. So he had the empathy and sympathy shown by Bala at that time, I can never forget. Because I met him many times. When he had joint pains, he used to go to Washermanpet, Lakshman's clinic, to do endoscopies. Enna Bala, how are you managing to go that much distance? He said, Rajini, I can driving no problem, only walking and thing is difficult. So even then, he used to go all the way and do these things. And he always used to call me because of my name, Superstar. After some time, he never used to call me by name. He used to call me Superstar. But the real superstar is him. So as all of you have said, all his attributes, all his qualities, he is unmatchable. He is a gem of a person. Of course, we also had social contact. My wife and his wife also, they used to meet and then discuss. He was so fond of his sons. He always used to talk about his sons. Of course, both of them are doing very well now. And when I went to see him on the last day of his house, his wife was simply uncontrollable. That lady, poor lady, and no amount of words could console her. She was sitting by him and said, "Kadavul poitar." It was very, very difficult to digest. Om Shanti Bala.
Thank you, sir. Professor B.S. Ramakrishnan.
So whatever I have to say echoes what we've heard till now, all the attributes, all the very positive attributes that Bala had. I knew Bala from the time that he was a postgraduate student when he came to spend a couple of weeks in Vellore, which used to happen in those days. And Bala was very popular. He was very popular with all his batchmates there and with this thing. And he used to interact very cheerfully with everybody. Like we heard, if anything had to be done, he would do it. So in fact, one of our PGs, in those days, to get a landline, to get a telephone line, you had to struggle with, it wasn't BSNL, then whatever it was in those days, we had to get. And so he told Bala, and within the next day he got it. In those days, that was days of waiting in queue for many years, and you had to put in your application and put in a thing. So he was that kind of person. When he left, he kept sending gifts to everybody. And again, that tells you the kind of person that he was, his character. So over the years, I got to know him very well, in a sense, in a society kind of sense, not in a very personal sense. I used to obviously see him at all the meetings. He would call up and say, you do this, you do that. You never refuse Bala. You can't. Because he had that kind of personality. We've heard that he was the glue that brought TNISG together. He and Dr. Panisamy together. Dr. Panisamy had other skills, but I think Bala was really the glue. He was the energy behind it. He pushed everybody together. And the great thing about him was that he was inclusive. He never left anyone out. That is the very great thing about him. Anybody, he would try to get them into the fold and try to make sure that everybody got their due. And that was something very admirable about Bala. Of course, professionally and other things, he's always supported us, and in terms of setting up the journal and so on. Again, he was extremely positive about that, and he started that. And wherever you are, Bala, and I'm sure you're up in heaven, looking down upon us and smiling and saying that, yes, we will keep this together. God bless you. May your soul rest in peace.
Thank you, sir. Professor TSC.
It's a personal loss to me. I know their family, his family so well. I'm so close to his family, his wife and sons. We used to interact very, very fondly. And every step in the life of his son used to discuss with me. He and Dr. were complementary duo, doing great things. But with me had a special attachment and relationship. The reason is, he's the only person in this world called me the Chandubai. Because I came from Chandigarh after my MD DM, and he was the first student when I joined MMC along with Dr. Ramar. So both were very senior to me, but immediately accepted me as teacher. In many meetings they regarded me as my teacher, even though I was just 28 years, I just completed that time. So I used to wonder, what is his personality? Is so good. As Dr. Raghuram said, 6-footer, and so active. And used to come with the two-wheeler, and you can't control his enthusiasm and energy. He's so energetic. And I could not see him suffering from this rheumatoid arthritis, becoming shorter and shorter and shorter. But only thing is, energy never shattered. He was so active, and he is inimitable and indomitable as far as his passion and love for ISG is concerned. And he always insists on clinical gastroenterology. I just want to tell you a small anecdote. I was the speaker and moderator for a symposium for the general practitioners on vomiting. And he was the chairperson. And the problem with him is he will prepare more than the speaker. And he'll ask so many questions. So I was posing a lot of questions, case history. And 40 years old lady, cirrhotic with a minimal ascites, come with the acute lower abdominal pain. That was the history. Bala said, no, I will make the diagnosis. So he kept on telling the DD. Finally, I said, no, Bala, what is this, what is that? He finally came out. You will not believe that. That was the case both of us had seen long back in GH. And that's a patient of ectopic pregnancy in a cirrhotic patient, 40 years old. Very difficult. He made a diagnosis. I still vividly remember that. What I want to impress upon the youngsters is, in the modern era of digital and so much of instrumentation coming up, is still the clinical gastroenterology holds good. And I can't accept it that his death, but only solace I have is, I didn't want him to suffer more. I've seen him suffering so much, I didn't want him to suffer. So one way, God doesn't want to punish very good people, keep on seeing them suffering. That's the only thing, Bala, I can explain. And my heartfelt condolences to the family, his sons, and his brother-in-law who is in Coimbatore. And I'll pray for his soul to rest in peace. Thank you.
Thank you, sir. Dr. VGM.
The chief in command is gone. That's how I look at him always. He was a commander in chief. Whatever we do, he has been the leader. Unimaginable leadership qualities. A man who lived with arete. Arete is a Greek word for a person who has lived to the fullest of his life. He was very happy, very contented, and he was a great leader par excellence. And I heard the news on Sunday night from Prem at 7:30 or so. I was in Isha Yoga. So I just I was in Dhyanalingam at 8 o'clock. I just sat and prayed for the soul of Bala. It was unimaginable. Radha and I both were there. We were totally, shattered because it was unbelievable for us. We never knew he was sick, that sick. I knew he had problems. From KRP sir, I used to hear. But the last few days, we were not in touch. And, the next day, Radha and I left to, Dubai for the World Congress of Gastroenterology. Monday morning, I meet KRP sir, a literally shaken person with tears in the eyes. I've never seen him in my life like that. I know him from 1985 when I joined Madras Medical College. He was my teacher. And Bala, like Rajni sir was with me at that time, 85. We both joined DM. Then he left abroad to Saudi. And then I was a solo PG who continued for the 2-year period at that time. And then Bala and Ramar sir both had joined us. I joined in 85, he joined in 86. From 1986, he's been a great friend and a philosopher and guide. And, the last program of ours was a Mysteries of Brain program, which we did from BGM Foundation and Kerala Tamil Research Center. That was the last program we watched, a virtual program of ours. And usually he puts up a message. He says it's good, it's super, super duper, all that he'll put and call me and sometimes congratulate me. But in this one, he had not put a message, but he had seen the program because I saw the double ticks. But I told him that we are hosting a conference in Coimbatore, December 15, 16, 17. I wanted him to be there. He told, எங்கப்பா வீட்டுக்குள்ளே நடக்கிறதே கஷ்டமாக இருக்குது, விளையாடுறியா, நான் எப்படி கோயம்புத்தூர் வருது, நான் வர முடியாது அப்படின்ட்டாரு பாலா. That was
thing he said at that time, then every time whatever I do, he'll just pass his comment. You know, in fact, I used to overshoot my time on the stage in many of the meetings, you know, by 2 minutes, 3 minutes and all that. பாலா உட்காந்துருந்தா திட்டு கிடைக்கும். வந்துடும் கீழே இறங்கினா, ஐயோ இன்னும் 3 நிமிஷம் நீ லேட்டாக போய், யூ ஷுட் ஹவ் ஃபினிஷ்ட் ஆன் டைம் பா. Please time yourself, reduce the number of slides, you can't speak so much. That sort of a, you know, command you used to, with that command you'll just convey that message. Then always, as all my teachers and stalwarts have put across, so he's been a great clinician par excellence, and whatever nama inikku vandu we did 25 endoscopies in the whatever camp அப்படின்னா, யோ நான் எத்தனை எண்டாஸ்கோப்பி ஒரு நாளில் பண்ணியிருக்கேன் உனக்கு தெரியுமா அப்படின்னா, சார் சொல்லுங்கள் சார் 60 எண்டாஸ்கோப்பி he has done in Raipata, government Raipata hospital. That sort of a go-getter and a hard-working person. இன்னைக்கு இருக்கிற today's youngsters, they can't work. I don't know, many of you, maybe the Chennai PGs are so good and hard-working, but I don't find that sort of enthusiasm to work long number of hours. We used to work something like 18, 19 hours and all that. So that sort of an enthusiasm, because I believe if you adopt a role, you have to live to your fullest. There's no question of doing anything inferior. He's been a great motivator and a great critic. Whatever we do, nalla irukna nalla irukku, nalla illana nalla illa, avlodhaan. And in Coimbatore, when he comes, I used to come, hey Bala, please come and eat with us. He says, chance kadayadu. Coimbatore na Annapurna dosa and coffee. So he'll say, I'll go to Annapurna and have dosa and coffee. I won't eat elsewhere. That sort of a thing. And whenever, he used to come to Coimbatore, he used to give a call to my PA and say that Murugan driver will come to pick him up. That's the same taxi cab driver who knows that Innova, he'll come and board him safely and transport him. He'll come and pick up a wheelchair from our hospital. They'll keep a very good wheelchair ready for him, and they used to pick up and go. That sort of a thing, he used to be a great mentor, philosopher, guide, as KRP sir was telling. We would have never done that Isgtnc at Coimbatore because we had only 10 months. Usually the conferences have at least 2 years in advance to plan, because J&K situation was so bad that nothing could be done. So Isgtnc, I looked at all of them and said, no problem. KRP sir only said, Mohan Prasad, no problem, go ahead, we'll do it. So he was the strongest backbone. I mean, Meridian Hotel, he was sitting and talking to Payaniji Periyasamy, PGP. And at the end of the meeting, PGP called me. PGP is my very close family friend from 1980s in the US. அப்போ இருந்து தெரியும். அவர் கூப்பிட்டு சொன்னார், மோகன் பிரசாத், யாருமே வேண்டியதில்லை, ஒரு பாலா போதும், இந்த மாதிரி யாருமே நெகோஷியேட் பண்ணி எங்கள் ரேட்ஸை குறைச்சதில்லை, சான்ஸே கிடையாது அப்படின்ட்டார். இட்ஸ் அமேசிங் இஸ் தட். ஸோ ஹி ட்ரை டு ரெடியூஸ் த காஸ்ட் given to spent on the hotel, saved all the money. And all the money that we earned in Isgtnc verbatim went for Tamil Nadu Foundation, the trust. So that was the seed money, which was one of the largest. Adukku munnale KRP sir conferences, Chennai conferences lala they earned. And as KRP sir was pointing out, he used to really threaten all the pharma guys and make them pay before the conference. That is something amazing. And pharma people அருமையாக பார்த்துக்குவார். எல்லா மீட்டிங்லேயும் உட்காந்து கடைசியாக மீட்டிங் முடிஞ்ச உடனே, அவங்களெல்லாம் விட்றாதப்பா, அவங்க தான்ப்பா பணம் கொடுத்தவங்க உங்களுக்கு, யூ ஹேவ் டு சப்போர்ட் தெம், ப்ளீஸ் கிவ் தெம் மோர் கூப்பன்ஸ், ப்ளீஸ் கிவ் தெம் குட் ஃபுட், ப்ளீஸ் என்டர்டெயின் தெம் அப்படின்ட்டு அந்த அளவுக்கு யூஸ் டு allow everything to be, everybody to be taken care of. That sort of a phenomenal personality I've never seen in my life. I don't think I'll ever see again. So we are missing a great friend, philosopher, guide. So I don't have more words. I just came back straight from the airport. I went to the house. I wanted to come the day I landed from Dubai. I wanted to come here. KRP sir said, we are going to have a condolence meeting, so please come on that day. So that is why I just postponed. I went, spent 45 minutes with madam, just consoled her. I don't think any words can console anyone. Bala's really left a vacuum for all of us, and we really miss him. At least all of us will miss him for the days to come.
Thank you, sir. Dr. Ganesh, sir.
Thank you, Vibha. Deeply shocked, I think, the day I got the message in the TNISG group. Probably the only time when Ubal put a message early in the morning. And it was very shocking to me. I have known Bala sir for a long time, been closely associated. Could say that he was my mentor also because most of the time he's been very encouraging. Great motivator, that's what I found. And a person who never take a no. So, in Tirunelveli conference, he wanted me to give the Dr. NMG oration. I was a little hesitant. I didn't know because I said, there are so many seniors before me, sir. Why don't you ask Dr. Ali? And I said, no, we have fixed you and then you should go ahead. And Dr. Jayanti also egged me on and said that, please do it. And then that's the sort of thing. He never takes a no. And he kept calling me again and again till he got the confirmation that I would do the NMG oration. I thank him very much for that, personally, for that chance to give the NMG oration. My deepest condolences to the family. And wherever he is, I hope he will keep blessing us forever. Thank you very much.
Thank you, sir. Dr. Padmanabhan.
Hello. My association started from DDHD, and of course everyone has talked much about him. The history of gastroenterology in Tamil Nadu is almost synonymous with the Dr. Bala. The remarkable feature is I have little bit temperament and all those things. Therefore, he tried to tame me, and that's the why I am standing here. Because of his taming here and there, he will coax me. That is the one remarkable aspect. And because of him, I am little bit becoming a gastroenterologist and understanding him. I have to thank him a lot. I express my heartfelt condolences to each one of you. Thank you.
Thank you, sir. Our President, Dr. Venkatakrishnan.
It was really shocking news that Professor Bala passed away when Dr. Prem informed us about 2 weeks back, minutes after he passed away. The first time I came to know Dr. Bala was, I think there was some CME program at Stanley Medical College, and I happened to come as a panelist, and he was very appreciative. And after that, I started interacting a lot of times. The second time was when we conducted the state ISG conference at PSG in 2007, and Dr. Bala was in contact with us, and he really helped us to really, in a way, he molded the whole conference. And Dr. TSE was the secretary of the ISG, that Tamil Nadu ISG at that point of time, and both Dr. TSE and Dr. Bala really helped us think. The greatest help came to us when he said that we should conduct the state ISG just before the corona in 2020 March. And he was very meticulous in this thing. He used to send us, the organizing committee, what are all the amount you can get it from he had a list of what will the contribution of the farmer, and he helped us a lot. And I still remember in 2011 when we conducted the ISG at Coimbatore, he twice came down to Lee Meridian, went through in the wheelchair to every part of it to organize it. And even in 2020 March, he just came one day to Residency Hotel and then met everybody and saw through the whole thing. He used to go through the whole place in ESG, and he was really in touch with us till we completed the conference. The last time I spoke to him was in June 2022. He was very appreciative of work, and I said we need all his blessings, and I did not really keep in touch with him. But strangely, I also felt that after I took over the president, he has not really attended any of these meetings. At least he had come on Zoom twice, and I asked him, "You have not come there." He said he was not able to move. So as all other senior gastroenterologists pointed out, I think he was really, I saw him as one of the motivators and persons who really resected Tamil Nadu ISG and took it to greater heights. And I found him to be supportive of anybody, irrespective of what you are, how older you are, how younger you are. It's a big loss, and I think we should lead the way in whatever the legacy is left behind. And my heartfelt condolences to the family. Thank you.
Thank you, sir. I think most of the TNAG secretaries have long association and interaction with him. I request Dr. Ravi to share his views.
So, I came across Dr. Bala in between 1986 to 89 when I was doing my MD in MMC. The actual first and best conduct was in 93 when I joined this college. Like Dr. Ramar, I also had a lot of personal problem. I really wanted to discontinue the course and go back to service. But then he advised me very strongly, and then I became a gastroenterologist. After that, few more students also came to my house, and I said the same thing to them, and they also completed the course. He was really behind me completing DM. So whatever I want to share is some of them are very personal. Actually, there used to be a wooden stairs so he always walks in that wooden stairs only. You can really feel his manly steps in this wooden step. You can identify Bala is coming from the sounds in that steps. And later on when I saw him in wheelchair, we felt really bad. Ravi and me always share. In fact, I spoke with him and I said, one of my patients who had a rheumatoid arthritis had both the hip and knee replacement. So I told him, I brought one surgeon from Apollo, sir knows him, to his house, and he agreed to see him and he advised surgery. Then he listened to us, but then he decided against anything. Then I went to Kerala for practice. After that, he started he used to organize get together through companies, and he always calls me. And personal relationship developed when he arranged a meeting in Coog. So many people we went, and we really become very close friend since then. And then the second time, I think Pondicherry, remember Kandasamy? So he became very, very close. And as a secretary, I had a very close association. We have spent hours on phone, many days, and sometimes it is very difficult to organize these meetings because on our own self. And if there is a delay, then we go to his. I meet him always in Apollo. What is that road? T Nagar. And you need to spend hardly 1 hour, 2 hour. You can complete the whole brochure in that time. He's very particular. Importance is given to all secretaries, president. He will know the ex-president, secretaries, and governing council members. All names should come. And the spell check, believe me, is very particular. No error should come in any of the names. Even the initials, name spelling, everything should be perfect. You think you have done that very well, there is no more mistakes. Next day he'll call us and tell, Ravi, there is a mistake there, and then we need to correct. So finally he has to approve it for the brochure to come without spelling mistakes. So, and at least 2 times I haven't agreed to his suggestion. Once when I became a secretary, he called me, said, Ravi, please withdraw. There is one more person already sent in his nomination, but I refused. Like that, twice I have refused. And initially he was upset, I know, but he never said any words to him. And then later on, after a year, he said, Ravi, when you wanted to become a secretary, I thought you may not conduct meetings like this, and so many other things. And then finally he was happy. So 2 weeks back, in fact, he called me for something, and then we were talking for a long time, 15-20 minutes. Then whenever he talked to me, he always asked me about the other Ravi, and he does the same thing with the other Ravi also. And then I told him, sir, Ravi and me want to see you. And before that, I want to say, Hari will know. There is one, he is very, very meticulous in studying also. He used to maintain a 80-page green notes. I don't know, most of his 80-page notes are with a green cover. He had several notes like this that he passed it on to us. And you must have Hari, and we all shared those notes, and we passed on that to some of the juniors. And then I told him, we want to see you, sir. He said, okay, da, paakla. And then when the information came from Prem, instantly Ravi landed on the same day night in Chennai. So both of us went to his house to see him in the morning. His face was so fresh. I mean, his wife knows what is our relationship with him, and we really couldn't control ourselves. And fate is that we both of us had to see him like this. I don't know, I couldn't bear it. Sorry. May his soul rest in peace.
Thank you, sir. I think this is one of the society where the surgical gastroenterologist is equally given importance. I request Professor Ratnaswamy to give back.
We miss this Mandira Punnagai, which binded us, all of us. It's a really shocking news. As Dr. Bal was telling, Bala sir sonna yarum thatta mudiyadu. Not only all the gastroenterologists, but every others involved in this organization also listen to Bala. I know him from MMC days, but we worked in Anna Nagar Peripheral Hospital. We were close to that. Probably at that time he left the service, I think, if I remember correct. Then we had the 2003 conference, Isgtnc, and he gave me a great role in that. And from that administrative capacity and all of you have stood, and it is no one can match him in that. He's a great soul. whatever Dr. KRP thought, it's done. It's Bala made it happen. And his achievements are so many. And as Dr. Bal said, he gave gastroenterologists, surgeons also great importance in this society. And we miss him. May his soul rest in peace. Heartfelt condolences to the family.
Thank you, sir. Dr. Kannan.
Bala sir's loss is like my elder brother's loss. எனக்கு ராஜா அப்படின்னு ஃபோன் வந்ததுன்னா அவர் தான். He used to always call me Raja. Every month at least 2 times he will call me, he will refer some patients. When I was in government service, he used to refer to me in government service. Even now he used to refer to me in Savita Medical College where the treatment will be very cheap. So, and he was instrumental in me getting elected as the president of Tamil Nadu ISG. He will say, Kana, Raja, va, sign podu. That's how he will command me, Real elder brother. I miss him a lot. I was very sorry that I couldn't attend his funeral as I was out of station due to some other personal reasons. May his soul rest in peace.
Thank you, sir. Dr. Hariharan.
I had the privilege of being Dr. Bala's student, and I had briefly been his colleague for about 6 months before I left the country. My first interaction with Bala was that, just how kind he was is that I took up something in gastroenterology by my mentor. And my mentor, and then at that time the professor wasn't seeing eye to eye. So, my mentor called up Dr. Bala and said, look, my student is coming, joining DM gastroenterology. This was in 1993. So, on the day of joining, Bala came out of the hospital. You know that unit 5 and that OP. He came out, and the first thing he warned me was that, "Dey, inga vandu annana pathila pesirada, unnu thochethruvaanga." So, he warned me, just didn't want to get me to get into trouble. The first thing was that he didn't want me to get into trouble. He says, he saw to that, I was there for 2 years, but ever since joining, the first thing was that I wanted to discontinue. I had my own personal issues, plus for some reason I didn't like to continue. But then there are 4 people who made sure I continued and completed and became a gastroenterologist. One, I'm sure Dr. Ali would know. Dr. Ali was one from the teaching faculty. I knew Dr. Ali before even I went to do gastroenterology. He was in Rayapeta when I was a PG. So Dr. Ali, Dr. Bala, Nagarkol Ravi and Trichy Ravi, all these 4 people ensured that I completed the course despite all my personal issues. They had always shielded me. From the PG side, these 2 Ravi should shield me. From the teacher's side, Ali sir and Bala sir. Wherever we go, when they were all talking about old people becoming, taking up gastroenterology, me and Ganesan was very young. I was about 27 when I joined gastroenterology. So we weren't looked upon, and we weren't encouraged in the to come into the department. But then they shielded us, they protected us, and Bala was instrumental in seeing that he protected me and saw to that I completed my course without having any difficulties. The other thing is that I saw him, his kindness has got no bounds. When you go to residency, when all these meetings used to happen in residency, first thing is after the meeting is over, I'll go stand near him. ஆனால் உங்களுக்கு மட்டும் தான் தனியாக வரும், எனக்கெல்லாம் ஒன்றும் கொடுக்க மாட்டேங்கிறாங்க. சரிடா நீங்கள் உட்காரு. தென் இவனுக்கு ஒரு பிளேட் கொடுறா. So you will get some special things from the residency. So you will always share the plates with me. So every meeting you say, "Dey unik irukada plate nee vaada." Now you'll keep next to me and make sure that you'll hand over the plates to me. One meeting I quietly slipped. Now I was feeling I didn't want to embarrass him. I just came late and I went off to the food. Then I don't know how he saw me, but then towards the end of the meeting he said, "Dey na unna paathira unukku or plate irukku inga va." He made sure every time, that's how fondly he will call me, said, "Hey, come on, eduthu poda vandu." So that's how he had always treated us. He was an extremely kind person. Very sad thing was that, I fell ill last year, but he made sure he called me before I had been in hospital, and I had changed hospitals. He ensured that, when the change was all happening, he checked that I was comfortable. He called me to say how my progress was, and when I came back home, almost once in 3 to 4 days, I had a call from him. "Dey kanne enala varamullada, nee kavalapadade, nee nalla irpa, kavalapadade, nee nalla irpa, ee kavalapadade nalla irpa." He was so encouraging. Enala enoda physical disability na vandu paaka mullada, unna vandu paakanonu enakku romba aasa, enala unna vandu paaka mudiyala. He kept on calling me, but ensured that his kindness, he was so kind, made sure that he was so encouraging. "Nee onnum kavalapadara, nee vanduruva." He was such a kind person. My last interaction was that a few months ago, when one of his relatives or his friends, I don't know, they got admitted in Apollo. He always checks, "Hey, the one path soluda." You call him and tell him that, "Sir, nalla nadakudhu ella, onnum prachana illa." Okay, nee paathukuda. So such a kind soul. Even despite his own difficulties, when I became ill, he kept calling me to check that I was okay and kept encouraging me. I don't think I'll find such a kind soul, and one of the most important persons because of whom I was able to complete my gastroenterology, and today I'm standing in front of you as a gastroenterologist. Bala was one who was responsible to see that I completed the course. And today I sadly miss him. I pray to God for his soul to rest in peace, and my sincere heartfelt condolences to his family. Thank you very much.
Thank you, sir. Dr. Yarvi.
It's a really sad day, but I'll tell about this. So many things I have talked about. My personal interaction come after 2003. அப்போல்லாம் தெரியல. 2011 பக்கத்தில் தான் வரும்போது தான் I was invited by Professor KRP and Bala for TTT program. One requirement was I should be a ISG national member. I was still that I was dodging the thing. And KRP phone பண்ணிட்டு நீ ஆகணும், I am getting cataract operation, you go and meet Bala sir. நான் அப்போ சேலம் என்ன பண்ணுறது, செக்கப் கொடுக்க சொல்லிட்டு அப்பாட்ட. My father and mother are very close. They are regularly meeting Bala sir in that GNCT road. போனோன்னு முதல் கேட்டார், எப்படி வாஜ்பாய் எப்படி இருக்கான்? I am supposed to be called Vajpayee because the most eligible bachelor in the entire, now also the most eligible bachelor, different matter, but that is being the case. He helped me, அது வரைக்கும் டாச் பண்ண 5,000 செக்கை. அன்றைக்கி செக் கொடுத்தோடனே அதான் I become TTT. சார் சொன்ன மாதிரி ஒன் ஆஃப் த மைனர் கேஷுவாலிட்டி ஐ ஆல்சோ தேர் இன் செட்பட் கிரவுண்டில், ஃபுட்பால் கிரவுண்டில். அண்ட் ஐ சீட்டட் ஒரு 1 hour 2 hours பாலா சார்ட்டி ஒட்டி சொல்லிவிட்டு ஐ வெண்ட் அண்ட் ஓட்டட் ஃபார் தட் ஓல்ட் மேன் ஹூ டைட் கருணாநிதி. வேற ஒன்றும் இல்லை. சார் ஜெயிக்க போகிறதுல நீ போய் போடணும் நான் போக மாட்டேன்னாரு. நான் நடுவில் லஞ்செல்லாம் ஸ்கிப் பண்ணிட்டு போய் ஓட்டு போட்டு வந்தேன். பாலா சார் யாருக்கு கண்டுக்காமல் போயிட்டு வாடினார். சரி, ஓகே 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 ஓகே. எப்பவுமே சொன்னார், இவர் கண்ணன் சொல்லார், என்னையும் ராஜா தான் சொல்லுவார், வாஜ்பாய் எப்படி இருக்கு அப்படின்னு தான் சொன்னார். ஒரு காலகட்டத்தில் ஐ வில் டாக் இன் போத் இங்கிலீஷ் அண்ட் தமிழ். ஒன் பீரியட் ஆஃப் டைம் ஐ வாண்டட் டு புஷ் அப். ஐ எம் ஆல்வேஸ் ambitious Aries character. He said, Bala, wait, you should be like a fisherman. கொஞ்சம் வெயிட் ஃபார் த டைட் டு கம். ரவி மீன் பண்ணது என்ன தான், ஓப்பனாக ஐம் டெல்லிங் சீக்ரெட். ஸோ அப்போ நார்மலி ஐம் ரேரி குட்டர். பாலா மேட் வி குட் வெயிட். இப்போ ஒன்று ஒட்டினா ஒன்று கிடைக்கும்னாரு. ஒன்று கிடைச்சது. தட் இஸ் பிகாஸ் ஆஃப் பாலா சார் அண்ட் கேஆர்பி சார். திஸ் ஐ ஹவ் டு மென்ஷன். அந்த டிடி விஷயம் இது சொல்லியாச்சு. அப்புறம் யூ வாண்டட் மீ ஆஸ் அ பிரசிடென்ட் இன் ஊட்டி. வி ஹேட் அ கான்ஃபரன்ஸ். யூ வாண்டட் மீ டு GA pathology பற்றி so many people are talking. Even Chandrasekhar sir சொன்னார், there was so much being done in pathology பற்றிலாம். Why don't you write a book? 3 years I am writing and finished a book, and I was telling Prem that we should inaugurate it whether this month or in the annual conference. சொன்னேன். பாலா சார்கிட்ட பேசுங்கன்னாரு. அப்போ தான் Saturday I was talking this to Prem. Sunday this night I was not in Chennai. I came on Monday evening to his house. Luckily it was postponed. So Monday morning it was postponed to Tuesday morning, Monday evening. Luckily I was able to see his face. I was able to talk with his second son. I went to all of his sons' marriages. One was at Ashoka Hotel, if I remember correct. We failed. Myself and Ravi, we failed in one respect. He wanted to get the 2020 ISC for Tamil Nadu. He made us sit in GNCT Road, 3rd floor. He wrote all the members. We prepared well. Everything was done, but unfortunately we were betrayed by back in the Kerala. There were different matters. So that it went to Pune. We lost it. Because we also could not conduct because of COVID. Nobody knew about COVID in 2018. Bala, konja pormai vengat. Be calm. Never be impulsive. So we mentor, guided. What I am in gastroenterology, some port. I will not say I am very junior person among this big harsh crowd. I lost personally a friend. He's a mentor to me. I can't say what the April. Definitely soul will rest in peace, no doubt. I don't have to pray to God to that thing. I only felt that their still wife was crying. The son was crying till the next day. Even that will be, it's insolvable loss. I wish to say heartfelt condolences to family. Thank you for the opportunity.
Thank you, sir. Dr. Jaswant.
Good evening to all of you. First, my contact with Bala sir was, his son was operated instantly for pseudocyst. So he never behaved as a great gastroenterologist. He just behaved as a father of a patient. We discussed other things, not the treatment with metal. Since then, we became very close. Of course, he maintained the high standard of ethics. Another thing, whenever I see him, he used to teach from his experience. Another thing was, we'll examine the VIP patients. So some people refer the patient with some history and all. But we should always ask the history from the VIP patients. Other people doing the wrong examination. Quoted me, he did 2 unnecessary rectal examination. Afterwards, that VIPs never turned up. No. Same thing also likely to happen to me. Because he shared his experience, I was saved from that. That many advice used to give. It is a very great loss to all of us. May his soul rest in peace. May heartfelt condolences. Thank you.
Thank you, sir. Dr. Aravind.
I met Bala sir for the first time way back in 1993. Actually, I was doing my MD General Medicine then. During my gastroenterology postings, I still remember, in those days there was only a blackboard and a chalk. Sir took a class on peptic ulcer disease for us. I still remember writing 2 columns, aggressive factors, defensive factors and all. And he asked us a question, why the left diaphragm is at a lower level? We all said because of liver pushes the diaphragm up. He said in a standing patient it cannot occur. The liver cannot push the diaphragm up, whereas the heart from above can push it down. A great thinker, it's a great personality he is. Then after a long time in 2003, during my gastro days, sir was in Anna Nagar Peripheral Hospital at the time. And after that very successful 2003 conferences, I still remember sir donated books to our library, all the libraries in Tamil, gastro libraries in Tamil Nadu. Then whenever you get a promotion or something done in the department, he will be the first person to congratulate us. He used to call personally. And during my posting in Anara as superintendent, once he asked me, whatever you want, you ask me, we will get it from the trust. At that time, Prem was also there. I requested audiovisual equipment. Sir gave 2 sets for us. And every time, whenever he calls us, he used to address us Raja. Enna Raja, enna veno. Every time he asks this, whatever you want to ask from the gastroenterology trust, we will give you whatever you want to you ask us. Even 1 month back, he rang up and asked me, how are things going on in MMC. We miss him a lot. I pray to God to give his family members to courage to bear the loss. May his noble soul rest in peace. Thank you.
Thank you, sir. Dr. Kanni.
My interaction with Professor Bala sir was from my PG days. When during the meetings, ISG meetings and the other academic programs, he used to encourage us to take part in all the ISG activities, and he was very sure that all the PGs should become member of the national body and the state body. So he will always encourage the PGs students to take part in all the ISG activities and make sure that all of them become members of the state and the national body. And he is a very kind person. Whatever problem we go to him, he used to listen and he used to give advice to us to solve the problem. And this death was irreparable loss to the entire gastroenterology fraternity and so many of us individually. At this crucial juncture, I pray to the God, may his soul rest in peace and his family members bear the loss with solemn.
Thank you, sir. Dr. Loganathan.
I think my introduction to him was in 1991 when I was an MD-PG. On a single day, we had a massive bleeder who came in the middle of the night. So I went and called him. He was a skilled assistant at that point of DAP. So he said, oh no, we can't do anything now, only stabilize the patient. He kept on bleeding. So went again, it was 2:30 or 3. Sending on Patharang sir. He came to the ward. Normally that happens only with nephrology and probably gastroenterology. He made some notes also. So next day morning I was late to the gastro OPD. So the professor was there. He didn't trust me. He came down all the way to the ward to see if I was saying the truth. He didn't talk with me anything from the gastro OPD to MSR ward. He asked, called the sister, was there any bleeder here? She said yes. Then he saw the case sheet. His notes was there. And that saved me. That's my first experience with Dr. Bala. I think to repeat what Sir said, it's very impressive personality. Very impressive personality. Very decent dressing. A real 6-footer. He never had any paunch. I think even late in the life also, I don't think he had any paunch like that. For me, it was all love and affection and care. That was what I cherished with him. There wasn't any command at all to me. It was all love. He also used to call me always Raja only. He had roots in Salem and he used to refer patients. He used to say on phone, எல்லாம் சொல்லுவானுங்க நீ காசெல்லாம் வாங்காமலாம் விட்றாத ஆனால் கொஞ்சம் கம்மியாக வாங்கிக்கோ. He was very specific on that. So that's another thing. And of late, for the past 7 or 8 years, whenever I used to call Dr. KRP, I always had the privilege to call him, thanks to you. கேட்டுட்டு அவரே சொல்லுவார், நீங்கள் பாலாகிட்ட பேசுங்களேன் அப்படிம்பார். There is a trust and responsibility he has given to him. And I think in the ERCOT conference, I saw him instantly around 7:30 or 8 o'clock. We were all seated in the midst of an extreme cold climate. I was just thinking we should do something in his honor. So on the stage only I went and asked Dr. KRP, can we name the hall as Dr. Balasubramanian's hall? He kindly accepted, but unfortunately it was in ERCOT. We didn't really make it very big. We arranged something very small, but I think it wasn't very well recognized. I think, I don't know whether you can take up that, whatever I wanted to do at that point of time, whether you can do it at some other point of time also. And last, and Dr. Jayanti corrected my theory paper, and Dr. KRP, I'm sorry, Dr. Bala was my examiner. Yeah, my DM exam theory paper, ma'am. So, Dr. Bala was my examiner. No questions asked. Only one question. Do you know why male is marked like that with an arrow up and for the female it's corrected with a round and a plus? I think the examiners always ask a question for which you will have to say, I do not know. If you say, I do not know, that's a positive thing and you will get a pass. I said, I don't know. So he told me the answer for that also. And we relished that moment sometime quite recently, probably 2 or 3 years earlier with another session also. So I always see them together and our first salute are always to them. So many things to learn from him. And as an organizer, I think they were all like complementary to each other. And over a period of time, I think responsibility to Bala increased, actually. It was good to see him always there. At some point of time, I wanted to take him to CMC, to see Dr. Dhanda, because we strongly believed in Dhanda, actually. I took my Professor MSR there once. I think that probably he got everything that Dr. Dhanda told MSR to get, and he got so many things from US also, whatever he has suggested. 2 things he couldn't take. I wanted to take Bala sir also there. But I said no. It's a family, much of immunosuppressants, and we don't. But I think we have seen some patients who had both the hips replaced, both the knees replaced. That auditor lady was coming in crutches, actually. Dhanda was able to make some difference in that life, and that lady became extremely active. She threw away crutches. Some of that, we have our own desires to make people not to suffer intensively, and I think I enjoyed his love and affection. That's what I will say. And we always had smiles. He always had smiles. And I wish and God be with the family Thank you very much for giving the opportunity.
Thank you, sir. Dr. Nirmala.
Though I have not worked directly under Dr. Bala or have been a colleague, but because by the time we joined, we finished it, Gastro had already replaced a voluntary retirement and he's gone from government service. But as all of you know that we were students of Dr. Jaiti, he used to call him for some classes as a faculty to study to teach us. And from that time, myself and Dr. Hema, we were the batchmates. And from that time, he always used to remember us. He'll never forget our names. Not even a single time he has not remembered my name. And from the time, whenever he sees us in every other conference, every other meeting, he'll be sitting in the front row. He'll always call us, give us some comforting words and ask us about the progress. And he has never missed to inquire us about our progress. And even after I've joined, I am at the Institute of Child Health. I'm working for the children there. He used to have some unaffordable patients, children, whom you would refer to us for the Institute of Child Health. Whenever you get a call from me, it will not be like from a senior gastroenterologist. It will be like your father or your brother calling, a senior elder brother calling you. Our patient Anparama, Pathukuma. I mean, it'd be so it not be like a senior person at all. It'll be like someone who's very, very close to you. Like, and I always, whenever I speak to him, I always think I always feel his fatherly affection or a brotherly affection from him. Yeah, his memories I'll always cherish his memories, and his absence will always be felt by me. And let the noble souls rest in peace, and let the family get the strength from the God to face the irreparable loss. Thank you.
Dr. Basumani.
So Professor Bala sir is warmth, encouragement, full of positive energy, and always with a nice voice, with a smooth tenor, and you cannot say no to him. So I've seen in close quarters when KRP sir and Bala sir were conducting a huge conference, in par with, you wonder whether you are in Chicago or New York when this World Congress and IBD meetings happened. So late night he will sit with all the pharma people like his own wedding. He will make sure, what is the conference bag, what should go in. We'll make sure everybody has been called and the protocols and programs have been run through, dry run, everything. So I thanked him many times. So this is a great opportunity of learning from great legends, and also I have heard so many things from Ravi sir. Everybody says that so many people have said, people have completed their courses. I wish I joined DM when he was there. I would have completed as well. So I miss you, Bala sir. So I really pray to God to give great strength to his bereaved family, and I will cherish his memory forever. Thank you.
Thank you, sir. Dr. Pirama.
Good evening. I think my association with sir has been only for the last decade or so after I came back here. I don't distinctly remember when I met him first, but all along the last probably 10 years, whenever I've had a meeting, whenever I've spoken, he's always called me, either, if you're sitting in front in in-person meetings, he would call me and tell me what I did right and what I do better. He always used to tell me you have to speak more louder, much louder than what you are doing. Even in times of COVID, when it was in these online meetings, he would make it a particular point to call me up on the phone and give me his feedbacks. I'm always indebted to him for his kind feedbacks, for his criticisms, very, very positive criticisms, critiques, when he would share his thoughts with me as to what I should do better. I was, in a way, fortunate to be a part of, in a way of, it's been last few days I've been associated with him also. What I admired in him was, despite all his, physical inabilities or incapacitating illness, he was always positive. If there's one thing that I want to take or remember him for, is that amount of positive attitude that he brought with him, despite all his physical limitations. I share my heartfelt condolences with his family. Thank you.
Thank you, Parama. And Dr. Bharat?
Bala sir means ability to appreciate, and it will be genuine, it will never be a flattery. However small it might be, he will make you feel so good. At the end of the day, it might be a small presentation, like how he is asked for a feedback of a patient and he'll say, "They were nalla postgraduate, mara araga present pannada." Even a small thing will be a genuine appreciation. We'll definitely miss him, and it's something which, that vacuum can never be filled. May his soul rest in peace. Om Shanti.
Anyone else wants to speak? Any youngsters?
A lot has been told about Dr. Bala sir. We've been seeing him as postgraduate in all the meetings. Whatever his problem is, he'll be there, right in front, through the meeting, till the end of the meeting, and he's always encouraging, he's always been encouraging. And one thing which is still there in front of us is his smile, his infectious smile and the positivity. It still beams with positivity. I think the best tribute we can do to him is carry forward his legacy, and see to that we do the things for the gastroenterology the way he wanted it. And Om Shanti.
Anyone in the Zoom link wants to speak? And anyone else in the audience? Before Prem comes in, because Prem is the longest association the society has. And whenever Bala sir calls me, and because the society, running a society is not always easy. There are a lot of frictions and something will come up. He'll say that ரொம்ப கஷ்டப்பட்டு இந்த சொசைட்டியை வளர்த்துருக்கோண்டா, ஏதாவது ஆக்ஷன் உங்கள் ஆக்டிவிட்டீஸில் you should not get collapsed. So that is the word he'll use. Some friction, somebody is having something happens in the society, he'll always speaks in that manner. And after his death, I feel he's one of the living God of the society, and our society is like a temple now. So we need to worship him for the service he rendered to this chapter. And I request Prem, after Prem's talk, I think we should stand for a moment of silence.
A lot of things have been told about Bala sir.
I would add a couple of things. When I first joined my PG course in Anana Peripheral Hospital, chief, everybody was down in the ERCP room. We were sitting there in the OPD. I went in, I asked me, sir, I'm first year PG, who has come to join the course. They asked, they olunga vela sevayada. Sir, na panno, sir, na olunga vela paakana, sir. And another half an hour's time, Professor Subhash came, and usually you call Subhash as Annaji. Annachi, அவன்கிட்ட பேசிட்டேன் ஒழுங்காக வேலை பார்க்குறேன்னு சொன்னால் நான் பார்த்துக்கலாம் அண்ணாச்சி. That's how we got introduced to Dr. Bala, sir. And after that, I actually got involved with sir in the 2003, and after that, and then in 2004 or 5, he called me one day and said, டே நீ வந்து கவர்னிங் கவுன்சில் மெம்பருக்கு நீ போட போகிறடா. சார் நான் எனக்கு இப்போ தான் சார் நான் முடித்தேன். அதெல்லாம் முடியாது, நீ போட, நீ கவர்னிங் கவுன்சில் மெம்பர் ஆகிற நீ. That's how my association with the society started in 2003-04. And even today it is going. In fact, after my thing, when Ravi sir and Joy finished, when Ubal became secretary, he called me, டே உபால் செக்ரட்டரியாக போகிறான், நீ வந்து இருந்தால் தான் நல்லா இருக்கும், நீ அவனுக்கு கரெக்டாக இருக்கும், நீ வந்து நீ ட்ரெஷரராக நீ திருப்பியும் போடு அப்படின்னு. இல்லை சார், இல்லை நீ தான் ட்ரெஷரராக இருக்குன்னு சொல்லி he made me the treasurer again. And I have apart from this thing, எதனாலும் பார்த்துக்கலாம் வாடா, that's what he used to tell me. And he has used to guide me a lot in my personal things. I think Kali sir and KRP sir know that we had a meeting in Kodaikanal, and had a lot of personal issues with me, and then we had a discussion about the thing. And once the meeting was over, everybody was leaving the place, and he called me suddenly, டே கிளம்பிட்டேன், நான் கிளம்பிட்டேன் சார், நீ வா, நீ கோயிலுக்கு போயிட்டு போகலாம் அப்படின்ட்டு. He took me to a place called Poomparai, which is about 7 kilometers downhill on the opposite side of Kodaikanal. There is a Murugan temple. That temple is known as Kulandai Velapar. And நீ வா, அங்கே போயிட்டு போகலாம், நல்லா நடக்கும் அப்படின்னு சொன்னார். I went there with him, and I prayed with him. And even now I have that the photograph of the deity in my puja room. And as he had wished, the personal issue which I had ended on a happy note. But sir is not there to know that. Anyhow, thank you, sir, for everything. Thank you, sir.
I think the Bala sir's son is on the Zoom. I think he'll speak for a minute.
Good evening, everyone. I'm Dr. Pani Subramanian's daughter-in-law. Thanks to everyone at the Society of Gastroenterology. We are very moved by the kind of affection you have showed. It really helps us grieve that we are not alone at this time. We are so, everyone has a story and a memory to share about my father-in-law. And he's been a great human being. My father-in-law lived a long life, and I'm sure his legacy will stay on forever. Thank you. Thanks to every one of you.
Thank you, ma.
I'm Pratap, Dr. Bala's second son. As we are from Dr. Bala's family, I thank you all for organizing this such a lovely meeting. Whatever you people are talking about my dad, this is something I've been experiencing for 38 years of my life. As I'm 38 years old, my bond with my dad is for 38 years. My father life, அவர் கூட நான் இந்த 38 வருஷத்தை வந்து திருப்பி ரிஃப்ளெக்ட் பண்ணி பார்க்கும்போது நிறைய விஷயங்கள். நான் ரெண்டாவது பையன். ஸோ முதல் பையனை வந்து 95ல வந்து he joined medicine. And when he joined medicine, that was a time when Dad started developing arthritis. Me and my brother has 5.5 years difference. He always used to say, why that 5.5 years is, that's a medical year, that's a medical degree duration. So once, by the time my brother finishes, I goes into medicine. So he makes sure that he can do something for me to get into medicine. And the 95, Anna was it, bro. And the arthritis pain, over what you make a tumor or already supplement cake on the arthritis or the full arthritis or the motor arthritis or planet peak at the time. But still, before I wake up, he leaves the hospital. 6 o'clock in North Madras, Dr. Lakshman to the hospital, go to endoscopy பண்ணிட்டு 8 o'clock from there from North Madras, he has to travel to South Madras to go to another peripheral hospital. At 8 o'clock, he has to be over there. And from 8 to 4, he'll be over there. From there, he goes to 6 o'clock to T-Nagar Clinic, approach in Chetty Road, T-Nagar Clinic. அது முடிச்சுட்டு 8 o'clock to மேலே வந்து அவரோட சொந்த கிளினிக்கு வர போவார். And all these things he finishes, come back at 11 o'clock. By the time he comes back, I'm already sleeping. But still I can hear him because around 1 o'clock, 2 o'clock, he started crying because of the pain. And my mom used to console him. And this was not just 1 day or 2 days or 1 week or 2 weeks. It was for years. And by 2001, I joined medicine. Our then I said medicine. And he just gave the pathway for me to settle my life. Again, 2006, I'm already in England for that. And the time I moved to we had an option. He had an option. He could have persuaded me to just stay with him. He would have persuaded me to just get into his gastroenterologist or something around it. I could have stayed in India. But he just gave me the option to do whatever I want to do. And I said, I want to go to England or America, somewhere I want to go. And he just given me the space to do that and work out. And whatever I'm here today, it's purely because of my dad. He's such a great man. He's such a great man. And we are blessed that we can see him throughout his life. Now, our பையன்கிறது வந்து எனக்கு ரொம்ப பெருமை. அதில் ரொம்ப சந்தோஷமும் கூட. எனக்கு முன்னாடி சொன்னாங்க 38 வருஷம் நான் அவங்க கூட இருந்திருக்கேன் நான். அந்த முதல் 25 வருஷம் வந்து ஒரு ஃபாதர் ஒரு பையன் செட்டில் ஆகிடணும் அப்படிங்கிறது ஒரு ஸ்ட்ரிக்ட் ஃபாதரும் பார்த்துருக்கேன். பட் பையன் ஓரளவு செட்டில் ஆன அப்புறம் last 13 years what I have seen him as a friend. He was a pure, genuine friend for me. And our close friend நான் என்னெல்லாம் ஷேர் பண்ணணும் for the last 10 years வந்து அப்பா நான் ஷேர் பண்ணியிருந்தேன். We used to, once I finished my work when I'm coming back for 1 hour, I used to call my dad. We used to talk. பேசுறதுங்கிறது சும்மா நல்லா இருக்கியா அப்படி பார்க்க ஓகேவா அது மட்டும் இருக்காது. We used to talk different things. Different things. Life எப்படி வந்துச்சு, எங்கேருந்து எங்கே வந்தாங்க, டாக்ஸ் ஏரி என்ன, something beyond medicine we talk about medicine as well. இங்கே வந்து பேசுகிற ஒருத்தரையும் நான் நேரில் பார்த்தது கிடையாது. But I can recognize you all because he talked about you all. And for him, the Indian Society of Gastroenterology, Tamil Nadu chapter, is like another kid for him. அவருக்கு வந்து ஒரு பிளட் போன் கிட்ஸாக நானும் இருக்கணும். அதே மாதிரி ப்ரொஃபஷனல் கிட்டாக வந்து இந்த ட்ரஸ்ட் எப்பவுமே இருக்கும். I don't know what else I can talk, but the final thing I just want to say is from what I learned from my dad was 3 things. 1, keep reading and explore the knowledge, gain the knowledge. Read not for money, read for passion. Number 2, enjoy your life and explore the world. Because he cultivated that idea of exploring the world, I have traveled to 68 countries so far. As of now, it's purely because of my father. He always persuaded me to travel and explore the world. And the third thing, the most important thing I've done as a father myself is, உங்கள் கை எப்பவுமே மேலே தான் இருக்கணும், கீழே இருக்கக்கூடாது. நான் இந்த செட்டில் ஆகி இத்தனை வருஷம் இருந்தோம், எங்ககிட்ட இருந்து 1 பைசா கூட வாங்கினது கிடையாது. Until his last breath, he made sure that he lived his own money. அந்த விஷயம் நான் ஒரு பையனா அவர்கிட்ட கற்றுக்கிட்டேன். நான் என் பையன்கிட்ட ஒரு அப்பாவா அவரை மாதிரி இருக்க முடியுமான்னு தெரியல. அட்லீஸ்ட் ஒரு 50% அவரை மாதிரி இருந்தால் போதும். I'll be a proud father. Finally, I thank you all for organizing this lovely meet. As behalf of Dr. Bala's family, thank you once again. Thank you.
Thank you, ma. Anyone else? I think that's all. At this moment, I think we plan to have Professor Balasubramanian Memorial Oration at every annual meeting coming from the next Trichy meet, I think. This is one of the greatest tribute we can give to him, I think. This is, I think, everybody will accept. I'll ask everybody to stand up for a minute of silence. Thank you. Please join for the dinner.